Okay, welcome everyone today to this Innovators Forum, and this is the second Innovators Forum which we are holding. We had one last year also at the same time last year in the same month. So the idea behind this was to showcase innovations which are done by our members, and this is a competitive session. I have with me the chairman of the session, Dr. Barun Naik sir, who is also the president of the All India Ophthalmological Society and head of Department of Ophthalmology, PD, Hinduja Hospital, Mumbai. And we have with us Dr. Lalit Verma, who is the president-elect of the All India Ophthalmological Society and director Retina Services, as well as the chief organizing secretary of SAO 2021. He is the director Retina Services at Center for Sight, New Delhi. Professor Maipal Sachdev, the immediate past president, today could not be with us because of another engagement. Dr. Rajesh? Dr. Rajesh Sinha is there? Okay, then myself would be there along with Dr. Rohit Shetty, consultant cornea and refractive surgery services, vice chairman Narayan Netrale from Bangalore. Again, Dr. Rohit Shetty doesn't need any introduction, and he's been a great innovator right from the beginning of his career. We have with us expert panel Dr. Rajesh Sinha, Honorary Treasurer of All India Ophthalmological Society, Professor of Ophthalmology, Cornea, Cataract and Refractive Surgery Services at Aarti Center, AIMS, Delhi, Dr. Partha Bishwas, Chairman, Scientific Committee, Director, BBI Foundation, Kolkata, as well as Director Trinetrale, Kolkata, Dr. Chitra Ramamurthy, Chairman, ARC, All India Ophthalmological Society, Medical Director, Eye Foundation, Group of Eye Hospitals, Coimbatore, and Dr. Suven Bhattacharjee, who's consultant, Nayan Eye Center, Kolkata, Director, MedInvent Devices Private Limited, again an innovator of innovators, and is very well known for his innovation. So if Dr. Rajesh Sinha has joined, Rajesh, can you introduce the innovators? I think he's not joined. Okay, Rohit, would you like to introduce?
Yeah, we start off with the so we can start off with the innovators, right? And
yes.
So I would like to welcome Dr. A. Fatima, who will speak about the tunnel for perfection in manual SICS. Dr. Fatima is a medical officer, Arvind Eye Hospital, Tirunelveli.
Thank you, sir. Shall I share the screen?
Yes.
Yes, Dr. Fatima.
Namrata, can you tell briefly about the marks and all? How?
Okay. So I think what has been decided is that the marks are being given to we have sent Google Sheets to the judges, and each of the presentation is going to be 5 minutes. And as was being discussed, please confine yourself to 5 minutes. There's going to be a queue which is going to be given at 4 minutes. And all the judges are going to give the marks, followed by compilation of the results, which will be done. And we do have 3 prizes, the first, second, and the third prizes, followed by the certificate of appreciation as well. Before we commence, I would request the President of All India Ophthalmological Society, Dr. Barun Naik sir, to say a few words. Fatima, then we can start your presentation.
Yes, ma'am. Then I'll stop sharing.
Yes.
Yes, ma'am. Yes, ma'am.
Thank you, Dr. Namrata, and good evening to everyone. So really, I am glad that this kind of program is being conducted, organized by AIOS, and so many people, because I saw the total, there are 21 speakers, which is really, it's a fantastic. And I was just quickly, I was scanning through the topics. So 2 things was striking, which really struck me. One was that a lot of people are taking advantage of the smartphone and developing some new things through the smartphone, which is very good thing, use of technology. And the second, I was happy that people, these 2 papers I saw, it was related to SICS, manual SICS. So that is something which is need of this country. FACO is not the need of this country. Of course, everything has to be there, coexistent. But the FACO, the manual SICS has its own place and it has its utility. And apart from this, I am really and one advice that if all those who are innovating something, if it is something which they feel that it has commercial value in future, then they should, before they start publishing or before they start propagating, they should first patent it in their name. Then only they should. Otherwise, if they publish, it means they cannot patent. So with these advice, I will not take much time because we are here to listen to all those innovators, in which all young enthusiastic innovators, we have to encourage them. So thank you very much, Dr. Namrata, again for organizing this kind of program.
Thank you, sir. Thank you so much. Dr. Lalit Verma, sir, President-elect AIOS would like to say something.
Nothing much, but very happy to see so many innovators in AIOS. And I remember a couple of years back when I was Chairman Scientific Committee, Rohit Shetty, the motivator par excellence, I should say, for helping me do a couple of sessions in AIOS, and I thank Rohit for the same. And I also see Suvan here, the great innovator, and BX ring has virtually challenged the malignant ring. Very happy to see Suvan here, and also Chairman Scientific Committee part of this program. And I think it will be a great session, learning for all of us, and best of luck to all the participants.
Thank you so much, sir. I think Fatima, you can start.
Yes, madam. Thank you.
Stamp the tunnel for a perfect small incision cataract surgery. The manual small incision cataract surgery is a boon to greater number of patients in developing countries, being cost effective and a sutureless technique. The major determinant of outcome in small incision cataract surgery is a sclerocorneal tunnel, as its architecture largely influences the induced astigmatism and proper delivery of the nucleus. The key components of sclerocorneal tunnel are scleral groove, side pockets, and corneal entry. Though there are various types of incisions described, the incisions that fall within Koch's funnel induce less astigmatism. The Koch's funnel is bounded by two imaginary curved lines which are 3 mm apart at the limbus. The frown incision described by Singer in 1991 is the one that falls perfectly inside Koch's funnel and also provides large enough room to accommodate nucleus during the Making perfect frown incision is not always easy, especially for novice surgeons, due to limited movement of the wrist joint in ulnar side by nature. So it will be useful to have a guide to make appropriate frown-shaped incision. Similarly, appropriate side pockets are of paramount importance to convert two-dimensional tunnel into a three-dimensional one, providing a wide opening to accommodate nucleus during delivery. The beginner surgeons tend to make either two small side pockets landing in difficult delivery or two big ones which will not take part during delivery of the nucleus. The third key factor, corneal entry, is preferably made 1 to 1.5 mm from the limbus. If the entry is made more anterior, it induces more astigmatism, and if it is made short and posterior, it does not allow side pockets to open and deliver nucleus. For the benefit of novice surgeons, we have brought out a novel device, SICS tracer, which could guide scleral groove, side pocket and corneal incision, thus helping them to make a perfect tunnel. Here, this device is being used on a goat's eye. It has prominent margins which helps to stamp the tunnel shape before starting sclerocorneal tunnel. After aligning the device to the limbus, the stamp is made over the sclerocorneal junction, and the corneal incision falls 1 mm from the limbus along with a margin which guides to make side pocket. The sclerocorneal tunnel is being made following the mark. We would also like to mention the device named Ranjan SICS marker available in the market to guide the external frown incision. this device is advocated for topical SICS surgery, whereas the device we have made will be more beneficial to the postgraduates and novice surgeons who land up in corneal endothelial damage and high astigmatism due to inadequate side pocket and inappropriate corneal entry. Since the corneal diameter of the goat's eye is larger than that of the human, the internal incision stamp in this video does not seem to reach the limbus, which will not be a case in the human eye. In human eye, this device is being used after gas sterilization. This device is a prototype. Further development with appropriate handle will give more ease to make stamping. Recently, with Orolab Madurai, we have come up with a stainless steel stamp for an easier use and effective sterilization. To conclude, this holistic device guides all the aspects of sclerocorneal entry and helps novice surgeon to make perfect tunnel and yield superior visual outcome. Thank you.
I think that was a very nice presentation. Any questions anybody would want to ask? We can take one question maybe, and then one or two questions, and then go on to this next presentation. What is the cost of this device, if we may ask you?
Madam, it is still in, no madam, still we are modifying, making, tuning up.
Have you patented it, Dr. Fatima?
No, sir, not yet.
I think I'm sure Dr. Suven will tell you that however small or however big it is, always patent it before this is one of my advice to all the young innovators. Never put up anything on a public domain till you have patented it. Don't look at it whether it's small or big innovation. Every innovation looks very small when you start.
Okay, sir.
Yeah, same advice. I think do it very fast because it looks quite promising.
Yeah.
So I was going to ask same thing only.
Yeah, but my comment over here would be that you have to see the cost. The cost of patenting is pretty high. So and the cost of protecting your patent infringements is also further higher. So whether you can prevent people from copying it and whether it's going to realize that value. So you will have small modifications of this, and that will not count as patent infringement. And then the cost spent on it will not be. So you'll have to see how you can protect it. Yes, patenting is always good, and provided it's commercially viable. That has to be perfect. Yeah.
Okay. Thank you so much, Fatima. Thank you.
Thank you, madam. Thank you, AIOS.
Thank you.
Thank you.
We call upon the second presenter, Dr. Pawan Kumar MG, PowerPoint animation for learning SICS. Dr. Pawan?
Yes, sir. Are you able to hear me now, sir?
Perfect.
Yes, sir. First of all, I would like to thank the AIOS for giving me this opportunity, and I'm started my presentation now.
2D animation.
Is it visible, sir?
Yes, it is visible and it is audible also, but there's a band which is coming on the right side. Sharik, can you see if you can do something about
Do
this?
it yourself
Okay,
with PowerPoint.
perfectly all right. Yes.
All of us know, excelling cataract surgery, we need to understand the basics and concepts of surgical steps, for which there are various theory books, diagrams, illustrations, and surgical videos. However, for a beginner, understanding a surgery can be complex. Animations are a simple way of conveying complex concepts so that everyone can understand easily. Surgical animations can simplify complex surgical steps, increases the confidence of the surgeon, resulting in good outcomes. However, to create such animations, we need to hire a professional spend huge amount of money and time. We need to keep explaining everything to the non-medical technician. I, being an SACS trainer, always wanted a simple and easy animation which I can myself make to enhance the teaching. I wanted a jugaad solution. Then we came up with an idea of using our most loved software for presentations, that is PowerPoint, to create various animations to teach SACS steps. With its features of drawing, transitions and animations, we created a bunch of illustrations. Let me show a few examples. To make fluorocorneal tunnel, we use a crescent knife, and we always teach the residents to get an ideal tunnel. We need to keep the heel of the crescent up while dissecting the sclera and heel down while dissecting the cornea. This is done to follow the curvature of the globe. If we don't change the direction, then we will land up in premature entry, and if we lift too much, we will end up in buttonhole. Beginners tend to fail making side pockets of scalar tunnel, which leads to bottleneck configuration of tunnel, causing nucleus to stuck at the wound, and hence creating the side pocket makes nucleus delivery smooth and safe. We should always inject the fluid or visco through side port after entering the AC. If we inject within the wound, it can cause desperate membrane detachment. While vectis delivery of nucleus, we should always visualize the inferior margin of the vectis. If the inferior margin of the vectis is not visible, it means it's under the iris and can cause inferior iridodialysis. While doing cortex wash, if we depress the lower lip of the wound, it leads to wound opening and collapse of the anterior chamber. At the same time, if we lift the upper lip of the wound, the fluid keeps the anterior chamber formed. This one is my favorite. It's called elephant roll. Elephant cannot be pulled using its tail. Similarly, cortex cannot be removed holding a thin cortical fiber. Right? It's easier to pull the elephant with its bigger trunk. We can remove the cortex by holding a bigger area. Finally, we should always remove the cortex sheet by holding its anterior part.
1 minute remaining, sir.
If we try to catch the posterior part to remove the cortex, it can lead to inadvertent PC cut and PC tear. We have uploaded a bunch of all these animations along with the surgical videos called the M6 series in our hospital official YouTube channel, ROTube. And the whole series has got a cumulative view of around 1 lakh plus. Recently, an international online library quoted our M6 series as one of the valuable resources to learn SACS. Thank you.
Thank you, Pawan. Dr. Chitra ma'am, any questions?
No, you're muted, Chitra. You're muted.
Very interesting. Both the first and the second videos have been really very nice, and I'm sure it'll find great use. There's no doubt about it.
Very useful, I think, for the.
And I have seen another innovation of yours earlier, Pawan. You have a very innovative mind. I think you should really keep doing things year after year.
Sure, madam. Sure, madam. Thank you so much.
Some people have that talent. Yeah.
Any other questions?
Subtle points, which you've put in, which normally people don't, discuss, and So I think that was a great video. Rohit, you would want to say something or
No, I think I've seen this in the past, and I did congratulate him on this thing during AIOS. Wonderful, and keep innovating for multiple other things. Retina, glaucoma. I think just don't stick to one area, because you need to move out of the comfort zones, even though if areas which is not your your prime areas of specialty. So let it be a comprehensive ophthalmic animation source.
Sure, sir. Thank you so much, sir.
Yeah, I think I've also seen this earlier. And Pawan, if I'm not, if my memory is correct, it is mostly on PowerPoint, correct?
Sir, it was top fourth, sir. It was under the apple tree, sir.
No, your presentations, these animations are mostly done on PowerPoint, correct?
Yes, sir, on PowerPoint, sir.
Yeah, so that was a clear message which you sent out every time, that you don't need a great animator or a software guy to do great work for you. PowerPoint is a powerful way of doing animations for our kind of work. So all kind of presentations, we can have a fair amount of animations with PowerPoint. It requires a lot of patience, but it's pretty good.
Thank you, sir.
Pawan, one last question for you.
Yes, sir.
Now, a lot of teaching modules are moving virtual or 3D based.
Yes, sir.
Have you thought of any plan where you want to bring this into a virtual reality platform or a 3D based thing? Because that is where I think students would enjoy doing it, because a lot of these things can be appreciated better.
So not thought about it, sir, but now you have given me that idea. I'll work on that, sir. Thank you.
So next year under the apple tree, you can use this, the virtual reality based.
Sure, sir. Sure, sir. Thank you, sir.
Thank you, Pawan. Wonderful. Ma'am, can I move to the next person?
Yes.
We have a very young presenter, Dr. Mohammad Yusuf here, who is going to speak about his use of needle. Dr. Yusuf, are you ready to share? You're muted. You're muted, sir. If you are having delay, can we move to the next speaker and come back to you after that?
Sharik, can you please help? We'll go to the... No, now he's on. Yes, Dr. Yusuf.
Yes. Can you hear me?
Yes, we can hear you. Can you share your presentation, please?
Yes. Okay.
Yes.
Okay.
Yes.
This is this.
Please move
my
on.
device is
Please,
small.
yeah. Please move on power on the slideshow.
Yes. Yes. This. Can you hear?
We can hear you, sir. Can you please
yes,
move to
Dr.
the
Yusuf, we can hear you.
Slideshow from the beginning.
Okay.
On the left, you have to click from beginning.
I want to introduce a new, very cheap, cost-effective device, tracker device, using a rotating needle with a low RPM decimeter. We need a low cataract need cost-effective device. This device is why need for a safe device. Cataract surgery is very safe in first world countries. In third world countries, it can be difficult for reason mentioned earlier. The ultrasound can cause posterior capsular rupture, wound burn, retina damage, and ocular hypertension. Need safety factors: simple procedure with less steps, reduce incision size, save endothelial cells, reduce edema, eliminate corneal burns, improve visual recovery time, and reduce vitrectomies. This solution is Yusuf's needle. It's supported by a low RPM decimeter, inexpensive, easy logistics, and low training barriers. This is the device components. This is a complete prototype for this system with a control box. Objective: low-cost cataract surgery and complication-free surgery. Features of device. This device consists of two parts. One is handpiece, two is control box. The phaco handpiece consists of three parts: body, tube, and Yusuf's needle. Body contains motor and wire connected with the control box. Control box controlled by a foot switch, tube containing Yusuf's needle. Control box has motor and transformer, microchips and software, which will do speed control, mode control, and control of aspiration rate. Criteria of Yusuf's needle. You know that easy penetration, sharp and serrated cutting edge, increased cutting surface, low speed cutting needle, generate low temperature, rotate at a fixed position. Low cost, 1% only commercial systems. Additional designs and device. History of phaco, previously Dr. Charles D. Kelman has tried with this device, but unsuccessful. Preliminary research with Yusuf's needle produce very low temperature. In this device there is no generate energy or emission of energy. So it is only coordinate temperature at the time of operation, only 35 degrees Celsius. Most extreme phaco devices produce high temperature. The device produce very low temperature. This is the data. This is data. This data. Irrigation and aspiration. Unlike other phaco devices, no production freeze temperature by this device, so no need of cooling this device by continuous irrigation as well. But we can use irrigation and aspiration to fluid evacuate emulsifying lens materials. The three different ways of phaco emulsification in one handpiece. On the basis of irrigation and aspiration, this device are three types: with irrigation and aspiration system, without irrigation and aspiration system, with only aspiration system. Incision during surgery. In case of with irrigation and aspiration system, 2.4 millimeter incision. In case of without irrigation and aspiration, only 1.6 millimeter incision. And with aspiration, only 2.4 millimeter incision. Sterilization of device. Most of the handpiece of the will be disposable, but we have an option of sterilization. Sterilized by tube parts connecting wire, irrigation and aspiration tube can be sterilized by autoclave. Heat sensitive instrument like body parts can be sterilized by formalin. And body part along with Yusuf's needle will also possible to make disposable. Also whole handpiece can make disposable for better patient benefit. Methods. I have some studies. Cross-sectional study period January 2014 to December 2014, tested on wood eye at the first test, randomly selected 50 both eyes and 50 human cataracted lens. Result:
1 minute remaining, sir.
Moderate penetration capacity. In goat's eye, no spinning of the lens, hence no denuding the endothelium, no other complication observed. Human lens are vitro successfully emulsified in immature and mature cases. The turns in the lenses in the gel-like substance very quickly. In case of a hypermature cataract, the process was prolonged in accordance with the aspected rate. You may choose my device because easier way to breaking lens nucleus with no energy emission. Less complication, especially no chance of posterior capsular range. User-friendly, cost-effective. You may choose whether capsular axis is good or bad. Capsular axis no tag present or not. So it can compare with femtophaco. You know that the femtophaco, the main idea is to capsular axis, find capsular axis for laser. So in this case, there is no matter for capsular axis. We can react if our capsular axis is not good, then we can perform this video. So it is very much advantage over traditional phaco that no need of special good capsular axis. No need of extra eye irrigation aspiration cannula. Three different type of needle we can use for three different type of cataract. In case of immature, one type, immature, mature, one type, and hypermature, there is another. Here is a sum. You see that there is a emulsification of lens very smoothly and freely. So I have not got my desert needle because lack of technological support. But still, I have made a alternate needle with this method. I believe if I got my desert needle, then it will be very more effective than this video. And you know that there is a inspiration. The needle is there is a in this case I have tried to aspirate with my simple cannula, but this is mounted. This is connected with my device, my control box, and that is why it is not handmade. It is also connected with a control box. In this case, I have tried to evacuate cortical material. Because there is no need of extra irrigation aspiration cannula, and this I can remove this cortical material with my control box. There is a there is a removing of cortical material.
I think you will have to conclude, Dr. Yusuf, because
there is no posterior capsular rupture. It is very much important. I have done some at least 50 cases, but fortunately there is no posterior capsular rupture occurred with my experiment. So I think it should be a great program. Thank you all. Thank you so much.
Thank you, Dr. Yusuf. Any comments from Dr. Partha, Dr. Suven, Dr. Chitra? Can you please stop sharing, Dr. Yusuf?
Yes.
Yes, perfect.
You'll have to answer. You'll have to. Yeah. So, Partha, would you want to comment on this?
Dr. Yusuf, congratulations for this innovation of yours. And a few questions could go on along with this is how exactly is the box working? How exactly the parameters are set? Those things they could be elaborated.
Actually, this is very simple. There is no need of any parameter. Only I will rotate at a specific RPM. You know that 2,000 or 5,000 or 10,000. I have setting. There is different type of options, so that I can run it with 2,000 RPM or 5,000 or 10,000. What is suitable for us, practically, you know that there is so many types of cataract, immature, mature, hypermature. So I can regulate my speed so that it will be smoothly, easily. There is no need of a vacuum. There is no need of another pressure or another so it is very simple device, and once you cutting this nucleus, then it will aspirate by this control box. Control box will
standardization
okay,
of device, sir? Any standardization?
I think Partha, from what we can make out, Dr. Yusuf has tested it himself, and others are yet to test it. So I think that standardization, like you're saying, would need to be done in future. Thank you.
We'll move to the thank you, Dr. Yusuf. We'll move to the next speaker, Dr. Deepika.
Dr. Deepika is there? I don't see Dr. Deepika there.
Who's next on the list, please?
Dr. Ashok Sharma.
He's also not there.
Dr. B. Jaya Prakash. Can admin please mute everybody, because there's some noise coming from
Dr. Alay, your mic is on. Okay, thank you. Dr. Jaya Prakash, would you like to share your screen, please?
Yes, sir. So am I audible, sir?
Yes.
Yes, please. Perfect.
First of all, it's a very good evening to one and all. It gives me immense pleasure, and I'm honored to be a part of this webinar. I thank AIOS and office bearers for this opportunity.
Your screen is not yet shared.
Sir, is it visible, sir?
No,
No.
Jayaprakash, it's not.
Yes, now it's coming.
Yes, we can see now. You'll have to start from the beginning, but
Yes, sir.
there's no sound in it, Jayaprakash.
It's full, ma'am. Is it still?
No, we can't hear anything, Jayaprakash.
Yes, ma'am.
Ma'am, he need to select the optimize sound and videos. Once he click on the share, there is a button now to click that button. Can you please stop sharing?
Prakash, can I suggest something? Can you please stop sharing and then open the video, cue it to the beginning, and then again open your screen share and then start sharing that particular video.
Unshare first.
And make sure your laptop is also on its full audio and the video audio itself is full.
You'll have to unshare, Jayaprakash. Yes.
Yes, sir.
Now you open the video on your laptop, click it, pause it, then share.
So once you share, once you click on the share screen, there is an options down below left side. Click the optimize, add the sound and optimize.
Hello, I am back.
Optimize.
You click on share.
Yes, on here.
Yeah. You're not getting any options?
Yes, sir. I'm getting optimize.
Right. Click on check both the options.
Try now.
Namrata, maybe Jayaprakash can mail his video to the admin and he can play from the back end.
Yeah, we can go to the next speaker, and by the time if things get sorted out, we'll come back to this again.
Yes, sir. Sure, sir.
Toric, can you please call Dr. Jayaprakash?
Yes, can you please give your number to in chat box?
Put it in the chat box.
Yeah, sure.
Meanwhile, I think
Nilesh Kumar, Dr. Nilesh Kumar is going to speak on direct imaging of gonioscopy by smartphone. So we'll come back to Jayaprakash once this is sorted out. Nilesh, you're ready?
Yes, sir. I'll start, sir.
Yes, please. Please.
Thank you so much. Good evening, everyone. I would like to thank AIOS for providing me an opportunity to present my work, Direct Imaging of Gonio Mirror by Smartphone. I'm Dr. Nilesh Kumar, and these are my financial disclosures. Gonioscopy is one of the most difficult clinical skills to be acquired, and thus even in majority of glaucoma clinics is not performed at baseline. In this letter to the editor, we raised the question that most of the recent advances in anterior chamber imaging, the surrogate to gonioscopy, are not cost effective and easy to perform. Raising question is important, and so is finding a solution to it. We innovated a novel technique using just a 4-mirror gonio lens and a smartphone, which was validated on 65 eyes and was published in the Journal of Glaucoma, and it also made it to the cover art. But how it began, just as a jugaad, this is the first ever image taken by Dix, and you can see the amount of improvement it required. The middle image taken with a transit lens with a macro lens to allow for more details to be captured, and the last image is the macro lens being stuck to the camera. This is a long way from what we did achieve, but the path was always exciting. We tried at least 12 different macro lens setup before achieving what we wanted. Once the macro lens setup was finalized, the device slowly began to look like a decent product. There have been 6 different prototypes before we could find a solution that fits majority of smartphones and gonio lenses. Finally, the device, which started as an idea in November 2018, was shipped as a product that can be used by everyone in September 2020, just 7 days before my DNB theory exams. And this entire journey would not have been possible without my mentor, Dr. Ashish Sharma sir. His own journey is an inspiration, and his guidance to prevent me from making his mistake has made the device what it is today, which is DIGS Pro, one of its kind, frugal commercial device in the process of patent application, which is compatible with 2, 3, 4, or 6 mirror gonio lens and smartphones with single or multi-camera setups. This is how the device is set up for use. We place the gonio lens in the adapter, which by design aligns centrally with the optics of the smartphone holding segment, where the smartphone, Android or iPhone is snapped fit. Normal camera app or the MI RedCam app can be used for clicking the image. The lens with the holder is applied in a normal fashion under topical anesthesia, and the patient is asked to look straight. The smartphone segment aligns beautifully with the lens adapter, and you just click using camera flash, as simple as that. These are few sample images using Vogue 4 mirror lens and few images using Ocular 3 mirror lens. In the validation trial for the device, where out of 280 images, 89% were found of credible quality. The kappa coefficient between slit lamp gonioscopy and the device was 0.65, while between 2 was 0.82, both implying substantial agreement to classify open and closed angle glaucoma. We also recently concluded a patient education trial on 200 patients, where 56% of the patient agreed for YAG PI when counseled verbally, but when shown their angle status using DIGS Pro, 93% agreed for prophylactic laser. As we went ahead on the journey, we realized the device use case went beyond what we had intended. When coupled with a slow motion videography, the dynamic nature of the angle can also be visualized in the angle closest aspect in a more physiological manner. Here we can see the angle slowly open up when the pupil constrict in response to the flash. It also doubles up as a diffuse anterior segment imaging device, which due to its inbuilt optics. The companion MI RedCam app allows us for easy record keeping, consultation, and also gives us an opportunity to collaborate with various research projects. One such project is to create using DIGS Pro images, which can create an AI overlay in the app itself. So when a technician clicks an image, he will get a notification whether to refer to the patient to hospital or not. But have we done all we could have done with the device? Not at all. The beauty of innovation is here to achieve is the reflection-free image. We are experimenting with various polarized light, filter, and external flashes to provide a reflection-free 360-degree image, which hopefully will be available soon. But with all this, have we solved the problem? I'm not satisfied at all, as the problem of acquiring the skill of gonioscopy still persists. And that is because we do not have a proper dry lab equipment that can allow the resident to practice their skill. So we have embarked on a journey to create that allows for an entire clinical exam mounted on a slit lamp. Our audacious aim, single practice eye for anterior segment evaluation, fundus evaluation, gonioscopy, as well as applanation tonometry. The first image obtained from the practice eye is really like the first image obtained from DIGS, and we take it as an indication to pursue till we succeed. That's what we imagine. So keep imagining, keep innovating, keep translating, and keep digging. Thank you so much. This is Nilesh Kumar signing off.
Thank you, Nilesh. I think that was a very nice presentation, and on a topic of gonioscopy, which is so very difficult to get images, is very difficult, and very well done. And the fact that you're still continuing on and on now with the eye model, I think with the in experimental situation, I think makes it even more even greater. So anybody would like to comment? Suven, are you there? Yes.
Yeah, I'm there.
Dr. Lalit Verma, sir, would you?
Before Suven comes, because Suven will ask very technical question, but but you see, I like this idea of DIG Pro, keep digging further. The most useful part which I thought was, Nilesh, that once you showed it to the patient, the conversion rate of YAG PI converted from around 60 to 93%. That was one thing which I would like to take it forward. because that is the ultimate aim. See, like I show my fundus photograph to the patient and tell him like diabetic retinopathy ye hai, what we need to achieve is this. So here is the photograph which you show and patient gets convinced. So good job.
Thank you, sir. Thank you, sir.
Yes, Suven.
Absolutely agree, sir. And Nilesh, I've seen this presentation many times, and the presentation seems to be getting better every time. With your video and the images, I can see the refinement in the quality, and that's progress. And like Lalit sir said, yes, seeing is believing, and showing is again making people believe. So I think we are seeing something good coming. And like you said, and I think it's more important as you found where the problem is to educate the people to do it. So standardization of that and training. So you're on the right track. Thank you for your presentation.
Thank you, sir. Thank you so much, sir.
Wonderful presentation, Dr. Nilesh. Very nice.
Thank you. Thank you,
We'll
ma'am.
find its use.
Thank you, ma'am.
I think we will move on to the next presentation by Dr. Prasanna Venkatesh Ramesh, the do-it-yourself, novel, safe and cost-effective ophthalmic cubicle, canonical in COVID-19 era.
Yes, ma'am. Am I audible, ma'am?
Yes.
Is my screen visible?
Yes. Yes.
Thank you for the opportunity, ma'am. So the do-it-yourself, novel, safe and cost-effective ophthalmic cubicle. So when COVID-19 happened, we had to convert the previous waiting hall into an OPD and investigation cubicle. Our idea was to minimize the patient movement inside the hospital premises by bringing all the ophthalmic gadgets under a common roof. So the pre-COVID waiting hall was converted into an OPD cubicle to evaluate all the ophthalmic gadgets that we wanted were brought into it. So we installed the cubicle on May 4th, 2020. The dimensions of the cubicle were 16 feet in length, 16 feet in breadth and 8 feet in height with a total surface area of 256 square feet. And this is the video from the insides of the cubicle showing all the eclectic setup that is needed for a day-to-day ophthalmic practice, a comprehensive practice rather. A slit lamp with an applanation tonometer, a refractometer, an NCT, a non-contact tonometer, another slit lamp. So we had 2 slit lamps, a confocal fundus imaging device, an electronic medical records, and OCT, optical biometry, and so on. So we provided sliders in front of every gadget so that we can close the sliders when we are not really using that instrument. Similarly, for the comfort of patients' leg positioning during examination, customized inward angulated dents were made for each instrument, each ophthalmic instrument. So there was a second layer of protection for the machine shield so that it adds as a secondary layer along with the primary cubicle, which is also another physical barrier. Each installation of the instruments were given 3 feet distance at least between one from the other so that social distancing norms were followed while the patient is having multiple investigations going on. This is the inside view from the cubicle showing the distance of at least 3 feet. And on the right hand side, you can see the outside view showing the distance between the 2 instruments. The materials used to make it was an acrylic sheet, aluminum beading, jigsaw cutting blade and adhesives, which when put together, we had the do-it-yourself novel and the cost-effective cubicle. So the acrylic sheet, 8 millimeter thickness, 4 in number were used, aluminum beading 2 into 2 inch, 20 pieces, and 4 into 4 inch, 4 pieces were used along with adhesives, jigsaw cutting blade, screws, bolts and nuts. And if you see the financial economic per se, the acrylic sheet costed approximately rupees 2.25 lakhs, the aluminum beading 28,000, and adding to it with it the adhesives, screws, bolts and nuts and the locks for the sliders and doors along with the air conditioner, it costed approximately 3.09 lakhs. Adding to it the labor and cutting charges, it came cumulatively up to 3.4 lakhs. And the additive feature of this cubicle is it can be opened with a leg with this appendage given so that there was no hand touch by the doctor or the paramedical staff, and it can also be closed by the leg. And since there is a physical barrier, the patient and doctor communication was quite challenging. So we installed 2 microphones, one inside and one outside for the doctor and the patient. Similarly, 2 speakers were installed, and we used to counsel the patients with the LAN connection from the machine so that we can counsel them with their own images as seen in this video, explaining with the help of a microphone for smooth audio-visual communication. So all the ophthalmic instruments were carried out with the doctor or the paramedical staff inside the cubicle with the patient being outside the cubicle. This is the clinical workflow as follows. And this is a video showing the transmission of case sheets or any important data that the patient wants to show to the doctor, the small rectangular opening from the outside to the inside. An additive feature such as a local area network or the wireless LAN can also be added inside the cubicle, and which can enhance the functionality of the cubicle. And validation and results in the last 16 to 17 months, 97% of the ocular patient examination were performed with our gadgets inside the cubicle rather than with the gadgets outside the cubicle, and it was quite statistically significant. Gadgets such as slit lamp, lens star, corneal topography, fundus, NCT and OCT were the ones which were performed inside the cubicle, and the remaining 2% were the synoptophore or the B-scan, specular and visual fields which were performed outside the cubicle. And discussion-wise, whenever the door of the cubicle or the sliders were open, air was flowing from the inside to the outside, creating quite a relatively unidirectional flow. And hand sanitation and physical barriers were also followed. So far, 29 medical and paramedical staffs have worked inside the cubicle. None of them have reported COVID positive within their 2 weeks of their duty completion inside the cubicle. And this is a figure showing a special air conditioner outflow for the cubicle alone separately, which is not mixing with the surrounding environment's air conditioner flow. And it is cost effective.
1 minute remaining, sir.
Yes, sir. It is a cost effective cubicle, less space consuming, easily constructible, and it has given excellent results and safety for the medical staff, especially when during the first phase and during the second phase of the lockdown, even this year, even before the 2-dose vaccination during the initial phase of the pandemic. And how do we take it forward? It is quite universally applicable. Though India is entering a pandemic stage, it has opened up new options such as it is an effective disposable tool. What can be done in a space of 256 square feet? It has really opened an eyes as to how the space can actually be made moving forward for ophthalmic evaluations. Though keeping in mind it cannot exclusively or completely substitute a tertiary eye care setting, where management process is still a dynamic one and constantly needs physical interaction. So it is a state-of-the-art feature for comprehensive evaluation, which has helped instill confidence and safety among the medical and paramedical staff during the pandemic. Thank you.
Can stop sharing the screen, Prasanna?
Yes, sir.
Any questions? The only thing which I which I want to tell you is our understanding of COVID as an aerosol-driven disease. That concept is completely changing.
Yes.
So one thing you have to remember is, and this is perfectly great. You know, the efforts you've taken is phenomenal. I think it needs a big round of applause to you and your team. But that was in the early stage of our understanding. How much of it's actually driven by aerosols? How much of it is all were in the first phase? If we really look at the modern day, you know, all that fumigations we do, so cleaning the surface, all that has extremely very limited role now. Until unless WHO comes out with the guidelines, which I feel is going to take a long time because nobody is aware of it. But whatever it is, I think it's a great job. I think we congratulate you for this efforts.
The only thing to bring back the confidence for the paramedical staff is one thing.
Absolutely.
And second thing, we again rediscovered ourselves that what could be done in 256 square feet is another thing that I agree totally.
I also had one question. How much time does it take for the entire conversion if somebody has to start from, A to Z?
To make the cubicle, ma'am?
Yeah.
It will take at least 10 to 14 days to get it assembled. So that is the time limit. Along with a good labor team, it takes 10 to 14 days.
Okay.
Dr. Ramesh, I have a question.
Must congratulate Prasanna because of two reasons. Because now retrospectively, we may have different theories, as Rohit was saying, but the kind of fear this COVID had created, at that time, I think,
yes,
at that time, this kind of jugaad which Prasanna and team created, I think 256 square feet and around 3 lakhs, whatever, is, I think at that time, it would have definitely, give you and as well as a lot of people a relief that within this small area, so much can be done.
Yes, thank you.
Thank you.
Thank you. We move on to the next speaker, Dr. Ashish Ahuja. You ready? And after this, Dr. Jayaprakash, are you ready with this?
Jayaprakash, is your thing?
Yes, I'm ready.
So after Ashish, if you can keep yourself ready so you can finish yours. Dr. Ashish, all yours. Ashish, can you start the presentation?
Hello. Yeah. Am I audible?
Yes.
Yeah, you are audible. Start.
A very good evening to everyone, and I thank AIOS for presenting me with this opportunity. I'll be presenting on the topic of post-vitrectomy recovery system. So, vitrectomy surgery requires patients to maintain prone position for a duration of 12 to 14 hours, which varies from 3 to 4 days to about 2 weeks' time. The real world scenario is that it is very difficult for the patients to maintain prone position due to various reasons, could be posture or health related problems. The challenge is to provide early rehabilitation in the post-surgery phase while providing face-down positioning support in the sitting or in the lying down position. PVRS device components includes a tripod-shaped furniture with a horseshoe-shaped cushion, which has a sensor embedded in the headrest. It's a pressure sensor. It's a patent-pending technology. So when the patient places his head on the horseshoe-shaped cushion, the data gets relayed via the SIM card to our server online. So the doctor and the patient can follow their progress on daily basis. PVRS device is very easy to use, and once the device is connected to the power bank, simply what the patient has to do is place his forehead on the cushion. PVRS system comes along with an angled mirror. When the mirror is placed below the eye level, patients are able to see the objects in front of them. Or if the patients want to use their cell phones or other devices, they may place it over the stand and use it. The rest of the PVRS device can be easily lifted from the stand. The power bank has to be separated, and the device can be used in the sitting or in the lying down position. So we did a pilot study to measure the compliance of patients to maintain face down positioning after vitrectomy surgery. All surgeries were performed by a single surgeon, and patients were asked to maintain prone position for a variable period as long as they were comfortable. 11 patients were included in the study over a period of 6 months, and the prone position duration varied from 4 days to 12 days. So we observed that the adherence was significantly better after macular hole surgery compared to retinal detachment cases. Also because the duration of face down positioning was for a lesser time. Adherence was noted to be higher amongst females compared to male patients. Most cases had a good surgical outcome, and patients were comfortable using the device and felt easier to maintain face down positioning using our device. So to summarize, we observed good acceptance of our device to measure compliance of patients after vitrectomy surgery. The significance of face down positioning to treat retinal detachment and other indications would be assessed in future studies. So PVRS is an innovative device to help patients maintain prone position. It helps to track duration of prone position maintained, and it's a patent pending technology, and this would help patients to improve compliance, to maintain face down positioning, and would help to improve surgical success. Thank you.
Thank you, Ashish. I think that was a very nice presentation, a simple way of putting things, a simple way of doing things. And the best part is that you have also put a stand over there. So in case they want to see their mobiles, they can see their mobiles and can interact on that. Is it, I'm sure, are you doing something to make it, commercially available to everyone? And again, what is the total cost price, per, how much do you spend in making the whole thing?
Yes, ma'am, we have started working on it commercially in Mumbai, and we'll be rolling it out in other cities. Currently, thing is, because there is electronic circuits and sensor, their server has to be maintained. So manufacturing cost just of the device comes to around 9,000 rupees. So we plan to rent it out to patients for about 3,500 rupees for 1 week or 2 weeks as per the physician's advice. So up to 2 weeks, like on a rent. And because this
Yeah,
entire
probably
thing,
because people will not need it for a prolonged period of time and would only need it post-surgery. Dr. Lalit sir, would you want to comment?
Yeah, Ashish, a good concept because positioning is a challenge and deters a lot of people from undergoing surgery. Also, fat, obese ladies, they will, just if you counsel them pre-op that position, and a lot of them may not undergo surgery. It's a good device. I'm reminded of my days at RP Center when we used to dig a hole on the head side and put a TV underneath just to keep the patients busy. Something similar modification which you have done and kept a power bank there to keep the patients busy. Good device, as Namrata was saying, because it's a temporary thing and costing may be an issue because patient purchasing that and renting it out may be a better option than patient purchasing because it will cost them. There are special pillows available which we ask my patients to. But day by day, the role of positioning is decreasing because we no longer advocate positioning for more than 1 to 2 days in gas-filled eyes, and in silicone-filled eyes, even a head down position like this may suffice. But nevertheless, a good this thing for people who may not agree for surgery, and then this may work out that their day-to-day work may not get hampered so much. Good.
Thank you, sir.
I think we can move on, Namrata.
Move on to the next one. I think Dr. Jayaprakash, if you're ready, can start.
Yes, ma'am. I'm ready, ma'am.
Yes, please.
So, Ashish, commercial launch kab ho raha hai?
So we have launched in Mumbai already, and few doctors in Ahmedabad have used it, and in Delhi also.
Send couple of pieces to Delhi.
Yes, sir. I'll send you, sir.
Yeah, sure. Thank you.
My video. I hope you all can hear the audio.
No, Jayaprakash, there's nothing running, only your no, we can't see the video. Yes, now it's okay. So start from the beginning. Now it's fine. Just start from the beginning. Yeah, just start from the beginning, please.
Can you see it now?
Yeah, we can see now and here also.
Pterygium is a degeneration of subconjunctival tissue which proliferates as vascularized granulation tissue to invade the cornea. Prevalence of pterygium has increased many folds, and that could be the result of dry eye during COVID-19 pandemic. Treating pterygium is essential when it causes corneal astigmatism, encroaches the pupillary area, cosmetically disfiguring, or if it causes recurrent inflammation and irritation. Pterygium is gently peeled from the cornea. Conjunctiva and the pterygium is dissected. Now, the head of the pterygium and its conjunctiva and the body excised. After excising the pterygium, the graft is dissected from the infratemporal bulbar conjunctiva. Before cutting the graft at the limbus, and by holding the free end with McPherson's forceps, the flap is pulled up and multiple small fenestrations are made with the help of 26 gauge needle, and then the flap is freed from its attachment at the limbus. flap is kept on the cornea and the scleral bed is prepared by cleaning the clotted blood, and gentle smoothing of the raw area is done for the fresh bleed. Meticulous care is taken to place the flap in the exact orientation, that is, epithelial side up and the limbal end along the limbus. Graft is stretched and the recipient area is completely covered. Ironing of the graft is done to have better adhesion. Direction should be from the limbus towards the periphery. Excessive graft can either be trimmed or can be tucked under the normal conjunctiva. Care is taken not to irrigate the flap once it is placed. Gentle cleaning of the excessive bleed is done with cotton swab. A moistened cotton swab can be placed on the cornea and wait for 3 to 5 minutes so that the graft is nicely adherent to the scleral bed. Conjunctival limbal autograft with autologous blood fixation in pterygium surgery is an effective and widely followed procedure. However, graft edema, graft displacement and graft loss are common complications. This technique has significantly reduced the graft edema, graft displacement and graft loss. Advantage of this newer technique with autologous blood fixation is to improve the outcome of conjunctival limbal autograft without the post-operative irritation by sutures and usage of expensive fibrin glue. Thank you.
Thank you, Jayaprakash. That was a very nice video that you showed. Fixation of the graft with the blood. The only difference, it has been described before, the only difference I could make out was that you're making fenestrations there on the graft. What is the idea of making, what was, in your mind when you made those fenestrations in the graft?
As we are doing fenestrations, the chance of edema getting under the flap and also lifting the flap is less. And you can also expand the graft as per the size necessary. And when there is a bleed underneath the graft, that can also ooze out through the smaller openings that we have made. So that is how it works. And I've seen a lot of cases with not doing a fenestration where the graft is totally lost on the next day or even the second day. So by doing this technique, I've not seen graft loss. There has been a few cases with mild retraction of the graft, and that was in the medialmost aspect where the graft was placed on the medial rectus muscle. So if the graft is smaller in size, the chance of edema or the chance of rejection or the graft loss is very, very minimal.
How is graft loss increased by fenestrations? You can say that it will not allow if any fluid to accumulate below, it will get seeped off. How will it prevent loss?
I think possibly the adherence. Okay, Jayaprakash, you answer.
Yes, the adherence is slightly more than when compared to a normal graft.
Nice.
Yeah, can I offer a comment?
Yeah, Suvin.
Yeah, Dr. Jayaprakash, wonderful video and wonderful innovation. What is important is whenever you are presenting an innovation, you must highlight what are the key features that you are adding. Okay, so you're kind of all that you wanted to say, Dr. Namrata brought that out, kind of squeezed it out of you. Because your video was mostly addressing, and towards the end also you said you're talking about autologous serum or blood being used for, as an addition. Your key points were a larger size graft and fenestrations. Correct, that was your innovation. So please focus on that in the next video that you make. And just to answer Dr. Chitra though, that it basically when you make fenestrations, this works for across all mechanical devices and things. When you make fenestration, they act as rivets. So they act as rivets and they kind of allow you to hold on to any tissue or any two surfaces, it helps get a better grip. So that's how these fenestrations work, right? So please try to focus on your innovational points or your inventive concepts more in your next video.
And thank you, Jaiprakash, for that thing. Dr. Rohit, can we move to the next one, please?
Yes, ma'am. Do we have the list? My phone is charging.
Okay. So the next one is by Dr. Rajesh V on 90D holder. Dr. Rajesh, are you there?
Yeah. Good evening, everyone. I thank AIOS for giving me this opportunity. So I would like to show my video.
Yes.
Is it visible, madam?
Yes.
COVID-19 had led to a lot of new practices like temperature screening, hand sanitization, and the usage of masks. All these new normal helps in the prevention of spread of COVID-19 infection. The mask not only prevents the spread of these microorganisms when we breathe out, but even if some microorganism escapes our mask, it also prevents the entry of these microorganisms into other patients' nose and mouth. So masks are the first and the strongest line of defense against COVID-19 infection. So all our patient comes to us with a mask. But there's always a small gap between the mask and the nose of the patient superior. So when the patient breathes out, the hot breath escapes via this gap superiorly. And when it comes in contact with the glass surface, it causes fogging of this glass surface. Here you can see when we are examining the patient with a 90 diopter lens, the posterior surface of the lens gets fogged with the hot breath of the patient. That will be totally hindering our view of the fundus. However expert we are in diagnosing all these fundus pathology, when our view is blocked, we tend to miss a lot of findings, leading to a lot of disaster. We wanted to handle this problem, so we designed and 3D printed a 90D lens holder. It consists of a stick-like holder and a case to fit the 90 diopter lens. And it prevents the 90 diopter lens from coming into contact with the fog, thereby fogging of this 90 diopter lens. This video shows how you can easily slide the 90 diopter lens into the case and close the anterior surface. And you can also tilt the 90 diopter lens in any direction using the holder. We also have the provision to insert a small cover slip, which we use in microbiology to prevent complete contact of the breath to the 90 diopter lens. This video shows the comparison between a normal 90 diopter lens and one inserted into a holder. The normal lens, there's always a fogging of the lens when it comes in contact with the breath of the patient. But once we use a holder, it completely prevents the contact of the breath of the holder, giving us a clear view of the fundus as there is no fogging. So we thought, why can't we use a do-it-yourself model as everyone can't 3D print it? So after much search, we found that the cap of the Dettol is of the same dimensions of the 90 diopter lens. So the 90 diopter lens can be easily fit into the cap of the Dettol. All we have to do is support the 90 diopter lens posteriorly and we can insert it into the cap. And it is ready to use. And it's nicely fitted. Even if you're going to tap it on a table, it doesn't come out. And it also never blocks your view of the fundus. You can see it gives very good view. And for removing the 90 diopter lens, all you have to do is with a cotton cloth, just push it from the bottom surface. And it comes out. You don't need a glue or double-sided sulfate to fit it. Just you have to insert it and then take it away. It just looks like the Dettol cap is custom made for 90 diopter lens. So we started using this. And we had a survey among all our doctors to find the usefulness of this 90 diopter lens holder. 62% of the doctors were of the opinion that it prevents total fogging of the lens, and 37% of the doctors said that it prevents fogging sometimes. None of them said it doesn't prevent fogging. 75% of the doctors were of the opinion that it gives a very good clear view of the fundus, and 50% said that it further prevents the reflections from the lid and lashes. 50% of the doctors said that no learning curve is needed, and 50% said that
1 minute
no
remaining,
learning
sir.
curve is needed before you start using the 90 diopter lens. None of them said that it is difficult to use. When asked about other advantages, 87% of the people said that it prevents touching of the mask or the patient while examining the patient. And 93% of the doctors said that it protects the costly 90 diopter lens from fall and fingerprint, thereby making the 90 diopter lens holder an ideal device even after COVID passes. Thank you.
Thank you, Rajesh. I think that was the simplest way of do it yourself.
Yeah, we accidentally found that it is perfectly fitting there, and because of the rim, it completely prevents the fogging also. So nowadays we get a lot of fogging. So it is an ideal solution and a cheap solution.
This is known as power of observation actually. You see, how come any would have thought that a Dettol ki bottle ka will fit into a 90 diopter lens. So that is most amazing that you found out that. But I'm sure it will work with or without COVID. It should be useful.
Yeah.
Useful device. Could solve this fogging issue forever. Which is 62%, 30% prevent that. By and large, I think people will definitely find the usefulness. A great thought. I think the honor should go to the thinker that how come you think that 90 will fit into that. Good.
We tried different things and finally this was very useful.
Normally it is the other way around. You first see the Dettol bottle thing and then you go to the, more box kind of a thing. Here it was the reverse thinking that you first devised that and then found an easy alternative.
Innovator and power of observation.
Yeah, even to that, easy alternative.
Good.
Thank you, madam.
Joel is also going to sell better.
Yeah. So
we move to the next speaker, Dr. Manvi. Are you here?
I'm here.
Manvi is there.
Yeah. I'll share my screen. So is my video visible?
Yes, Manvi.
I'll play it now. Thank you.
In ophthalmology, especially with your retina, we have multiple scenarios with delay in triage. Every day, millions of people face emergency situations the world over. To ensure that they receive optimum treatment, triage is vital. In ophthalmology, especially with your retina, we have multiple scenarios where delay in availing treatment can result in irreversible vision loss. For improving follow-up for the patients with high-risk retinal conditions, we innovated the E1, E2 emergency coding system. In the course of patient care, we noticed a significant problem. Patients requiring emergency care fail to avail the treatment on time, losing precious vision. Why does this happen? The doctors who are treating the patients have excellent knowledge about the patient's situation, but are they unable to convey the emergent nature? And what about the counselors who schedule the patient's appointments? They lack the depth of knowledge on the diseases and often in a busy OP counsel all patients in a similar fashion. Consequently, the patient does not understand his disease and the need for prompt treatment. Mixed signals are perceived from all the quarters and there is a delay in treatment. So we went out to devise a solution for this problem. Not something complex, but easy and elegant. Born out of this dilemma was the E1, E2 emergency coding system. Various diseases were coded into 3 categories and tabulated with their treatment options. This was made available to all the doctors and counselors. Coaching the counselors on these conditions enabled targeted counseling. The categories even included very high-risk cases like endophthalmitis, retinopathy of prematurity, retinal detachment due to giant retinal tears, who had to avail treatment within 1 to 4 days of consultation. E2, which covered a large majority of retinal diseases like proliferative diabetic retinopathy, age-related macular degeneration, retinal vein occlusion, were to avail treatment within 10 days. Category 3, including very few scenarios in which your retina, like SFI or surgeries, could avail treatment at their own convenience. The E1 cases, in addition to targeted counseling, received reminder phone calls on the day prior to their appointment and were followed up. In case of a missed appointment, they were tracked and reminded again. The E2 cases were tracked to check if they had availed treatment and received reminders only in case of missed appointments. As a result, over the course of 3 years, we saw that 80% of the E1 cases reported on the same day and 12% another day following a reminder. Similarly, a total of 96% of E2 cases availed treatment. The system is not without certain burdens imposed on the counselors. Increased counseling time, need to make phone calls, and manual tracking do add to their workload. Currently, we implement the E1 E2 system across all our hospitals and continue to coach our counselors to improve their knowledge and communication. The strategy is also now integrated into our electronic medical record system and involves audio-visual or group counseling in some scenarios. This system can be further strengthened by the fully integrated EMR that sends automated reminders to patients and gives pop-up reminders to counselors. By working as a team, doctors, counselors, and patients can have a positive impact on visual outcomes.
So thank you, Manvi. I think that was a very organized presentation on, how to organize yourself and put them into various categories. Anybody has any questions?
Yeah, Manvi, congratulations for this very elegant way of actually triaging what is so important, what we actually tend to miss, especially in large hospital setups. I just had a question because it's a study that has really been very well followed up. So do you have a way in which you have categorized previously how it was done, and now with your triaging system, how well it has fared? Is there any comparative analysis of the non-triad system with the triad system, which would really make it very, very strong in the sense that other hospitals should be able to emulate?
That's an excellent question, sir. And actually, way back in 2000, I mean, we have been following the system, and it's a part of our regular work pattern since 2013, mid 2013, when we innovated this. And at that point, about a year later, we actually thought of looking at this, But what happened is it's very difficult to derive this data retrospectively. So when we tried to do this in 2014, early 2015, what we realized is when we went to our hospital system and we tried to retrieve cases like proliferative diabetic retinopathy is one which you have high risk PDR in E1 and normal PDR in E2. Or retinal detachment surgeries where macula or GRTs fall in E1 and maybe a little older RDs could go into E2. And we actually tried to retrieve 1 year numbers of PDR case sheets coded in our system came out to be 40,000. And because the earlier case sheets were manual, and there was no coding then, we actually would have required to retrieve every case sheet, and a person who can understand if it's E1, E2 would that would be a doctor, would have to sit and screen through those case sheets to see. And because of the large numbers, sir, we just couldn't do it. We tried to do it for retinal detachments, which itself, it was just not possible, sir. I think you can understand that. We would have loved to have that data, and I would have published it by now if I had it.
Thank you. Thank you, Manvi. I think we'll move on to the next presentation.
Thank you.
Dr. Narendra Singh Verma, who is going to be talking about Toric marking topographer.
Yeah. Thank you, AIOS, for the opportunity. Yeah. This is my presentation.
Dr. Verma, shall we share the presentation?
No, he's already put it. It's okay.
Yeah, shall I start?
You have put it.
Yeah. It is about the dynamic topographer. Dynamic topographer. This is the first dynamic topographer, you can say.
I present to you an app for toric axis marking which has been integrated with topographer. This device is an LED-based topographer coupled with the EasyTor app for easy and error-free toric lens axis alignment. Recall the face of the poorest and weakest man you have seen and ask yourself if this step that you contemplate is going to be of any use to him. Considering this thought of Mahatma Gandhi, can we make expensive technologies more accessible to poor patients? Prevalence of cataract in ages greater than 40 years is about 7.5%. 1/3 of them have an astigmatism of greater than 1 diopter. Presently, toric or toric multifocal lens implantation is the best option available. but the reliability of outcome depends mainly on perfect axis alignment. Misalignment of 10 degrees can cause a loss of 35% benefit provided by toric lens and usually requires surgical realignment by using basic operating microscope, immersion A-scan and manual keratometer. Surgeons are implanting monofocal lenses with minimal post-op refractive error since almost a decade. The majority of them cannot maintain expensive instruments, so they are reluctant in implanting multifocal toric lenses, as there are higher chances of unpredictable outcomes due to errors in axis alignment occur during measurement of axis and marking of axis, inability to measure angle kappa and angle alpha, inability to measure anterior and posterior corneal astigmatism and nature of astigmatism. Hence, there is a need for an all-in-one system which is easier, faster, patient and surgeon friendly, that is non-cumbersome to use, economical and also with an option to link with existing instruments, reliable with low maintenance. The common causes of errors in toric lens axis alignment are errors due to manual marking and errors during measurement due to head tilt. Manual marking is a contact method usually done by bubble marker or freehand marking. There are chances of error due to smudging or wipeout of mark. In this case, when the head is tilted from left to right, there is significant 27-degree error in axis measurement. In the right eye, the axis changes from 88 to 61 degrees, while in the left eye, the axis changes from 114 to 87 degrees. This system consists of 4 parts. Illuminating disc having 600 LEDs. Camera to capture high quality images in different light conditions. Processing unit provides multiple apps. Wireless display streaming capabilities to multiple devices. Topographer with the EasyTor app can measure axis and nature of astigmatism of anterior surface, angle alpha and angle kappa, prediction of posterior corneal curvature with respect to anterior, and finally assist in axis alignment of toric lens by marking axis of alignment on colored photograph. The basic steps are: during topography, capture a photograph of eye in the same head position. Calculate axis of alignment using Barrett's toric calculator. Use the EasyTor app to mark axis of alignment on colored photograph. Use the photograph intraoperatively for axis alignment. Measure K1 and K2 from manual keratometry. LED-based topography for measurement of axis of astigmatism. Simultaneously capture photographs for axis marking in same head position. Prediction of posterior corneal curvature with respect to anterior corneal curvature by comparing P1 and P2 Purkinje images. Measure IOL power by immersion A-scan. Demonstration of toric axis alignment. From menu, select toric axis marking. Enter patient data. The colored photograph of the patient will be displayed automatically. Enter 2 parameters, site of incision and axis of alignment calculated by Barrett's toric calculator. Increase the size of axis mark ring such that the dotted ring coincides with the limbus. The green light is automatically displayed, which denotes the final axis of alignment of toric lens. You can also display lens silhouette in the axis of alignment. There is also an option for marking 3 landmark points as yellow lines. The axis of these lines is displayed at one end. Save the picture. It can then be magnified and rotated as desired. Picture can be displayed on mobile, tablet or other display devices in the OT for axis alignment reference. Picture without lens image can also be saved and used as a reference to visualize iris structures. It eliminates parallax errors as the iris is very close to lens marks. You can also mark landmark points during the initial stages of surgery, which can be used for axis alignment or to double check the axis of alignment using degree gauge. Final check of axis alignment of toric lens. You can also compare lens marked with iris structures to eliminate parallax error as the iris is very close to the lens marking. Pre-op and post-op pictures compare the axis alignment. Only 1 to 2 degrees of misalignment is present. Demonstration of apparent chord length mu, angle kappa and angle alpha. Select picture from the gallery and adjust size of the picture, move it in the center and freeze it. Now adjust optical axis, white circle on the border of limbus, then adjust pink circle of pupil size on border of pupil. Then move chord mu icon in center of light reflex. Save the picture and increase the size as required. In the first case, patient is suitable for multifocal lens, but in the second case, he is not. In the first case, it is better to prefer extended depth of focus lens as optical axis, that is wide circle center is away from visual axis, so angle alpha is more than normal. These pictures are useful to easily explain the eye condition to the patient when they are unfit for multifocal lens.
Thank you. This is a dynamic topographer. This is the first dynamic topographer. If I am having, will give me some time, I can explain. It can provide 3D modeling of the cornea, and it can decrease the error of the keratometry because it takes the picture from 2 centimeter. I am telling dynamic मैं इसलिए कह रहा हूँ क्योंकि ये एक ही जगह से पिक्चर नहीं लेता है. टोपोग्राफर जो है 2 सेंटीमीटर आगे पीछे कंटिन्यूअस फोटोग्राफ लेता है. तो उसकी वजह से क्या होता है कि हम जो है 3D मॉडलिंग कर सकते हैं और P1 P2 की वजह से एंटीरियर और पोस्टीरियर सरफेस का 3D मॉडल बना सकते हैं. और उसकी वजह से केराटोमीटर जो रीडिंग है AIOS 700 वाले मास्टर वाले जो है वो टेलीसेंट्रिक लेंस यूज कर रहे हैं और इसमें हम कंटिन्यूअस फोटो लेते हैं मल्टीपल्स. वी कैन टेक 1000 फोटो और उसको जो है उसकी वजह से हम एरर को केराटोमेट्रिक एरर को नलीफाई कर सकते हैं. और जो 3D मॉडलिंग जो इसका जो हम अभी यूज कर रहे हैं उसमें कैसा होता है मैडम, जैसे समझिए कि एक कोई LED है. जैसे ही हम जब आगे से फोटो लेते हैं 10 सेंटीमीटर फोटो ले रहे हैं, बाद में पीछे 12 सेंटीमीटर पीछे 2 सेंटीमीटर पीछे मूव करता है कैमरा, कंटिन्यूअस फोटो लेते हैं. जो सिस्टम जब पीछे मूव करेगा तो LED की लाइट जो अंदर की तरफ शिफ्ट होगी क्योंकि ऑब्जेक्ट पीछे जा रही है. तो हर LED जो है इक्वल रेशियो में मूव करनी चाहिए उसका ग्राफ. और किस पॉइंट पे फास्ट मूव करती है फिर स्लो मूव करती है, उसका मतलब वहाँ एलिवेशन फास्ट हो रहा है. तो केराटोकोनस अर्ली केराटोकोनस को हम इसमें डायग्नोस कर सकते हैं. P1 P2 जैसे P1 P2 जो है जब जैसे ही डायनेमिक है आगे से पीछे जब मूव करेगा तो दोनों की इमेज जो है इक्वली मूव करनी चाहिए. और P1 P2 अगर कहीं पोस्टीरियर कर्वेचर में डिप्रेशन है तो वहाँ P2 जो है ना उसके साथ नहीं मूव करेगा तो दोनों में डिफरेंस आएगा, दोनों की कर्व में डिफरेंस आएगा. इस विल शो कि P2 जो है मतलब पोस्टीरियर कर्वेचर वहाँ पे डिप्रेशन है, एंटीरियर में नहीं है. हो सकता है कि एंटीरियर में डिप्रेशन ना दिखे एपिथेलियल की वजह से.
Thank you so much, Dr. Verma. I think this is a very elaborate this thing which will require, a presentation in greater detail. But it is a very good initiation start and a very good way of, doing it and doing it yourself. So thank you very much for your presentation. Partha, if you do not have questions, or Chitra, if you don't, then we can move on.
Comment, Dr. Narendra, very interesting.
Yes, very interesting.
Said, we definitely need to see an elaboration of the whole.
Yeah.
Would really give the insights. Again, when you go on to the elaborate project profile, then I would also ask you to have a comparative study between what you have now and what your study gives us, or what your device actually gives us. So that's very, very pertinent to understand the strength and importance of your project.
Okay. Thank you, sir.
Thank you so much, Dr. Verma. We'll now move to the next presentation by Dr. L.A. Banker. Like Dr. Nayak sir said, that smartphone is the fashion of the day, and his presentation is going to be on smartphone-based portable and affordable ROP screening device.
Thank you very much, ma'am, and the AIOS for giving me this opportunity. I'll run my video, which was pre-recorded, so you can all listen to it. Hello, friends. Today we'll present our innovation of the development of smartphone-based affordable and portable ROP screening device. I'm Dr. L.A. Banker from Banker's Retina Clinic, Ahmedabad, and I have worked with Yash Nagar Sheth, who has a startup known as C3 MedTech for the development of this device. To start our presentation, we'll present a small video as to the project that we are
doing. The development of an inexpensive smartphone-based retinopathy of prematurity examination device. Our device is compatible with major smartphones, iOS and Android, and major indirect lenses like 20D, 28D, and 30D. The device is very intuitive and easy to use and requires very minimal training. The flashlight of the smartphone is the source of light for conducting the screening. Locate the red reflex of the dilated infant on the screen of smartphone. The user has to move lens ring towards the smartphone to capture fundus data as per the working distance of the indirect lens used for screening. These are the actual recording taken from the smartphone during our screening. The result is high-quality images for diagnosis extracted from videos which are comparable to currently available contact ROP screening devices. Image showing magnified view of stage 3 threshold disease. Similar comparative image showing laser marks and peripheral TRD. Image showing severe avascularity with end-to-end looping on vessels. Showing vessel tortuosity and severe avascularity in posterior zone 2. Image of macular dragging and laser marks. With the development of this device, we will be making ROP screening affordable and accessible to all our practitioners.
So the main advantage of our product is it is portable, affordable. It can be used by anybody, a nurse or a nurse practitioner or a paramedical person, or even you can train anybody to use this. We are developing a telemedicine app along with this, and the most precious, important advantage is that you can attach any kind of smartphone with this device. We are developing a smartphone app, as I told you, and this is how it will look like. The home page will include all the details of the patients, the visits, and the full data. And when you click on the image sign, you will have all the images lined up, and you can generate a report on your right and give it to the patient. You can also have various visits, and if you click on all the visits, you'll have the comparative photographs visit by visit. The workflow essentially, as we all know, any technician or optometrist can take this device to any NICU or any college or any rural area, capture the images, load it up to the app, and then the retina specialist or the ROP expert through the app can give their report, and you can even refer the patients to a higher center. So essentially, when you compare this with the conventional indirect ophthalmoscopic method or the very expensive contact cameras like the RedCam or the Neophorus, ours is extremely cheap, very small, lightweight, portable, handheld. It does not require any fancy computers or softwares. All you need is a smartphone and this device, and you can get excellent images.
1 minute
So we
remaining,
hope
sir.
through this, we will make ROP screening more accessible even in the rural areas. Thank you very much.
Thank you very much, Dr. Ale Banker. Did I see correctly? Some of the pictures were actually better than the actual pictures. Some photographs were sharper on the smartphone than on the actual, camera.
Yeah, actually, slowly we are getting, more and more efficient in capturing the images. And particularly the images up to zone 2 anteriors, we are getting exactly or even better than a RedCam or Neophorus. And we've submitted a paper on publication where we have done a mass study where we have compared these images along with the RedCam with masked readers. So it is under it is under review in the Retina Journal. The other advantage is that the device that I showed you is just a RedCam, but the same thing, we just changed the ring and you can use it for the adult photography. So we are using it for diabetic retina screening camps where we send a team to the peripheral rural images areas and even in the primary healthcare centers, and we are training the nurses just to take pictures of diabetic patients. And it's so easy that most of us feel that within 2 to 3 months, even a person who is non-educated, totally non-educated, is able to retrieve very good images.
Thank you, Dr. Ali Banker. Dr. Rohit, would you? Yeah, part 2. Yes.
The device cost around 8,000, and it's extremely light. The material is very, very light. And very recently, we've come to know that we are very fortunate that the Department of Science and Technology, they have accepted our proposal for a grant for further development of this device, particularly for ROP. And we are trying to distribute it to all the peripheral ROP centers. So that's a big plus point.
Dr. Lalit sir, Dr. Partha.
Yeah, excellent, LA, as usual, a lot of innovation you keep doing. How is it vastly different from Dr. Ashish Sharma's device from Coimbatore? He has a more or less similar.
Yeah, MI RedCam.
Yeah, MI RedCam, yeah.
So the advantage with our thing, it is just the base is a very soft thing which rests on the cheek of the baby.
That
so
I noticed,
even if the baby moves, the entire device moves, so you don't lose the field of vision. That is the major advantage. And then you can keep changing the lenses. If you want to have a wider field, you can put in a 28 diopter. If you want a very good view, which I showed, it was a 20 diopter lens, and you get an excellent picture of the disc and macula of the posterior pole. And because it's a 3D image that is being captured, I think we get very good resolution also.
Good.
One small clarification, Alay, excellent innovation. The thing is, for an ROP screening, how long would it take for an optometrist and or a nursing staff to get trained in and adept in the photography of the image?
Right. Good question. We've researched on this because we get a lot of queries when we present this. We've sold about 120 devices so far all over India, and a few also outside India. Roughly, we've guessed that it takes around between 50 to 70 screenings per person to get real good images. So what we tend to advise is we start telling the optometrist or the technician to first try and screen the adult with the dilated pupil. So they get the technique of how you shift the lens towards the phone. And once they know how to focus the image, then we ship them to the pediatric patients. And it's very easy. I mean, you just mummify the babies, you wrap them in a cloth, so they hardly move, and you have a person who keeps the baby's head still. And then you hardly have any movement. And now we are getting images right up to the aura. So we've been very fortunate that we can entirely tilt the entire device so that we have it's kind of indirect ophthalmoscopy basically. So you're doing indirect ophthalmoscopy right up to the aura, and you can capture a video. So all the time, the main thing is you keep recording the video, and from the video, you can just take the pictures, whichever picture has a good resolution.
Thank you, Dr. Alay Bankar. I would now request the next speaker, Dr. Prithvi Chandrakant, to give his presentation on iolscope.
Good evening, everybody. I would like to thank AIOS to give me an opportunity to present my innovation in this forum. I'll be sharing my video. I hope it's seen.
Yes, it is.
The iolscope. No conflicts of interest, no financial interest. Microscope has been a boon in the field of science, which has made us realize that there is a world that is too small to be seen by the naked eye. It is the visual bridge connecting the macro universe to the micro universe of a living organism. It has become a useful tool in the field of ophthalmology, which helps us in research, diagnosis and treatment. Use of these microscopes in ophthalmology is largely restricted to laboratories, which is costly, time-consuming and labor-intensive. There is growing interest to develop tools for health monitoring which can be used in clinical settings and field cam setups. Point-of-care diagnostics are being developed to offer advantage over the conventional laboratory-based evaluation method, providing portability, automation, faster processing time, reduced sample volume and lower cost. The goal of point-of-care diagnostic is to make testing widely accessible, such as in clinics, outpatient departments, camp, ICUs and PHCs, etc. Smartphones are being used to acquire anterior and posterior segment photographs with impressive details, which established it as a good tool for point-of-care diagnostics. Its use in fields such as microbiology, pathology, parasitology hasn't been much explored. Here we describe an innovative device which can be easily made and acts as a microscope for point of care diagnostic using just a smartphone and IOLs, called the IOL scope. What's required? Chart paper 4 into 2 centimeters, intraocular lens 30 diopters for 4 numbers, micropore, paper puncher and liquid adhesives. How to prepare? Take a chart paper of 4 into 2 centimeters, cut it out using a puncher. Make a circular punch on the paper. Take the IOL and place it at the hole created. Using a liquid adhesive, glue it to the chart paper. Let it dry. Once it dried up, you can take the second piece of IOL, keep it on the first IOL and put the liquid adhesive. Do the same procedure for the next 2 IOLs. Your IOL scope is ready. Now with the help of a micropore, you can attach the IOL scope onto the camera of a smartphone. How to use? With the help of torch for illumination of the sample slide, the IOL scope is used to acquire microscopic images of the sample. The image and video is then recorded and can also be relayed for expert opinion. Here are a few videos of rhizopus, fungal hyphae, caterpillar hair, rhinosporidiosis and inflammatory cells. We conducted a comparative study in which corneal scrapings of 194 corneal ulcer cases were analyzed using both IOL scope and compound microscope. The IOL scope had a sensitivity of 96% in analysis of KOH mount and 100% in the culture mount for fungal hyphae detection. We also conducted a similar study to identify parasites like Demodex and sheep botfly larvae. We also published an article in the Indian Journal of Ophthalmology in which the IOL scope was used intraoperatively in a case of rhino-orbital cerebral mucormycosis to detect mucor hyphae during a FES procedure to determine clear edge for surgical debridement. These are the comparative images. Have you ever imagined that an IOL which is used for cataract surgery to help patients see the macro universe with a small tweak used by anyone to see the micro universe? Thank you.
Wonderful.
Fantastic.
Thank you.
Thank you, Prithvi. I think microbiologists should now take a cue from this, and they can do their entire microbiology with this. And I don't know what will happen to the lab microscope companies who actually, do this after adding a camera to it.
Yes,
Only very innovative, Prithvi. Yeah. Very innovative. I think must congratulate you. Out of the box.
The previous note, Prithvi, can you quickly explain the physics behind the imaging?
Yes, sir. This is actually basically you can see here. This is actually a one lens which we used. We have combined 4 IOLs and Aurolab. With the help of Aurolab, we have made one lens which can give almost up to 500 diopter power. And the basic principle is making your camera into a macro lens. Making use of a smartphone camera, transforming it into a macro lens. So the smartphone is not actually having macro. The newer iPhone 13 has macro lens, but it's not that great as much as we require. The magnification not as much as which we can do with this one. So basic principle is making the camera into a macro camera so that we can take images. That is a basic principle.
Like a magnifying lens, it's become.
Yes.
Diameter of these lenses that you have, is it a particular diameter that you have fixed?
Yes, actually, the thing is, all this goes back because I am very interested in photography. So I've been doing photography over a long time, and I know the optics because I use macro lenses to take photos of minute housefly and all those kind of things. So what has happened is I've used 30 diopter lens IOL of rigid PMMA, and that is what I have been doing. And the same thing we have done the same thing with this one also. The PMMA rigid IOL has been used. 4 30 diopter lenses was used, and this was actually a 100 diopter IOL, which is in air it comes up to 500 diopters. So yeah.
That is,
thank you so much, Prithvi.
By that.
Yeah. So we move on to the next presentation. The next presentation is going to be by Dr. Dayakar Yadula. He is already at it, and it's on Aroma, Arvind Outreach by Mobile App, a new model for community-based screening. So Dr. Dayakar.
Good evening, madam. I got some problem with my screen share. I'm coming now.
Yes.
Yes.
So I think.
I'm coming.
Yes. I think the best part is that with such simple innovations, spectacular results are there. Yes, Dr.
Good evening to all. Thank you AIOS for giving me this opportunity. I'm going to play my video.
Aravind Eye Care System conducts nearly 1 lakh cataract surgeries per year from outreach. COVID-19 pandemic has forced us to shut down our outreach services, so rural patients had no way to access care. We came up with an innovative way to reach out the rural population with our mobile application named Aravind Rural Outreach by Mobile Application. Aravind, in collaboration with biomedical engineers of Johns Hopkins University, has developed a comprehensive screening protocol that allows the community healthcare workers or volunteers to conduct a home-based screening via a mobile application. Volunteers are trained personnel who can perform visual acuity assessments, basic eye examination, gather patient information, capture good quality image of eye, and enter the details in the application. This app is low bandwidth and uses algorithms similar to WhatsApp to upload images and data with only 2G network. In areas without internet connectivity, data is stored and automatically uploaded later when sufficient network is available. At present, we are focusing on anterior segment pathologies like cataract, corneal ulcer and pterygium, as these conditions are major causes of preventable blindness and can be treated effectively if they are detected at the right time. With this training, volunteers will carry out a home-based screening from their own and nearby communities and will give them a referral slip to use when they visit a mini camp. The details entered in the application will be reviewed by an ophthalmologist from base hospital, and the final opinion of the doctor will be conveyed to the patient by the coordinator via phone call. Based on the opinion, patients who need further treatment has to visit the mini camp. Mini camp is a controlled camp conducted for a small number of patients who were invited via phone call. An ophthalmologist will be present in the mini camp to finalize the diagnosis.
Patients whose vision is not correlating with cataract or suspicion of posterior segment pathology will be asked to come to Base Hospital for further examination and treatment. Patients diagnosed with cataract will be brought to the hospital in the vehicle arranged by the camp sponsors. Admitted in the hospital. And post-surgery, they will be dropped in their homes by the hospital vehicle. This innovative mobile application is a more effective way to reach outreach patients and will change the way we do outreach. We believe this can strongly aid us in reaching unreached patients to eliminate needless blindness.
Thank you, Dr. Dayakar, again for a very insightful presentation for community at large. So, any questions from anybody?
Yeah, Dr. Dayakar, again, you've been running this app for quite some time, and this protocol during this COVID time. What are some figures that you have got from the screening protocols that you have devised?
Excellent question, sir. Like we started this app thing, everything in the last 1 year. Then we did a pilot study. Then the prototyping, everything is finished. Voluntary training is over. Now the validation study is going on. In the validation study, there is a comparing with the ophthalmologist diagnosis with the app diagnosis. It is accurately coming to 95%, sir. This is an anterior segment diagnostic, sir.
Very good.
Thank you, Dr. Dayakar. We move on to the next presentation, and the next presentation, I think Dr. Vineet Joshi is not there.
He's not. I saw him in the group.
Dr. Vineet had asked me to present on his behalf, but you'll have to check whether he's available.
I think we can take that in the end then, Rohit, if...
yes, ma'am.
Let's get the presentation from the speakers who are there, and then while the result is being compiled, maybe.
But you have to tell the judges whether this is still...
Dr. Vineet is available. He's a participant.
He's there?
Yes, ma'am.
Yes, Dr.
Dr. Vineet, chalo, good. Okay.
Shall I share your presentation, Dr. Vineet?
Yes, please go ahead.
Just give me a minute.
A very good evening to all of you. I'm Dr. Vineet Joshi. I'm from Pune. I'm consultant in cornea and anterior segment in NVPI Hyderabad. And I thank AIOS for giving me this opportunity to present on the AIOS Innovators Forum today. And I'll be taking you through a story of developing an anterior segment imaging device, which is a simple universal attachment for patients. And to begin with, I would like to show you an image and a video sent by a patient from his native village where he couldn't follow up with us for a period of 2 to 3 months. Now, isn't that the quality of image and the video that you would expect from a patient for a teleconsult to make some clinical decision making? How did we reach till here? And to get to that, let's understand what is the problem that we dealt with. Existing imaging equipment that we have are bulky and they are stationed primarily at the tertiary centers. But when it comes to increasing the quality of imaging towards the secondary centers or the peripheral centers, that need was highlighted during the lockdown when most of the patients who were at risk, like the patients with infections, injuries, the extremes of age and the lower economic strata, could not access these the urban centers with these equipment. Patients have equipment, the smartphone with advanced cameras with them. At least one person in the household has a smartphone with a camera. Now, the only problem lies is that the smartphone camera is not optimized for imaging in ophthalmology, especially its optics, the focus, the illumination, and the intuitive, the smartphone imaging app is all devised around imaging scenic photographies at distance, but not at micro imaging for anterior segment structures. So to deal with this, we investigated the problem and we analyzed a set of around 340 images sent by patients during the lockdown. And we figured out that although the patient is feeling that they are sending the images of the eye and expecting a treatment for the doctors, and most of these images lacked the clinical frame of interest. There was inherent shake, lack of focus, poor illumination and lighting, and most of the images lacked magnification, where the image used to grain out on zooming. The result was 84% of images were not acceptable to the clinicians for decision making, and even more so, they were not acceptable to even make a decision whether a patient needs a higher center referral or not. To add to this problem is the variety of phones that are available in the Indian market with customizable smartphone camera options, which makes to find a solution even more difficult. There are solutions existing in the international markets where there are excellent devices available for smartphone-based slit lamp photography, but these are bulky devices, these are complex, and the more the complex the device becomes, it becomes more customized for that particular smartphone model, which were primarily tested on Apple and Samsung phones, which the Indian population would not have that much in common. So we tried to figure out a solution where we were constantly seeing the quality of images captured using smartphone, our solution, and the slit lamp images, and we were trying to bridge this gap by implementing more technology, standardizing the imaging process, and keeping the cost into consideration for the patients. So we came up with a universal solution with a hardware and a software where the device can be portable, universal, and stable, and the capturing of image could be very easy on a secure sharing platform, intuitive, and the results could be consistent. We call it Grabby, whose distance is calibrated such that the image captured using the app will come within the focal length of the lens of the smartphone camera. So we conducted this small study and we figured out that the quality of imaging did improve using our solution. And in the column 1 and 3 is the images captured during Grabby light, and on the column 2 and 4 the same eye is captured using slit lamp photography. And we could see that the clinician's acceptance rate to make a decision had increased up to 53%, and triage the patients to higher referral centers had increased up to 88%. Now we've figured out a particular way of how to capture the image, how to get those perfect camera settings, converted this protocol into the app. Once we figured out this, we trained the patients and we handed it over to them. As you can see, these are the images sent by the patients from their home. Some of them are post-DSEC, post-DMEC patients, and also some of them were post-TABCL infectious keratitis patients. Most of the problems with the perspective, focus, illumination, and resolution were solved, and the quality of imaging had improved significantly. Imaging and documentation was pretty smooth, and across the different anterior segment diseases, as we captured these images into the clinics, and we had the confidence that we can translate this to our patients. This was the same patient which I showed earlier. This was a patient underwent PK, could not follow up during the lockdown. So we trained his son and he used this device at home, and we were able to follow him up for 3 to 4 months. We couldn't check the IOPS, but the patient's graft was doing well and we could titrate his medications accordingly. Even for children who had problem in coming and referring, this child had been diagnosed with Pythium keratitis. We trained her father to use the device. And the patients know very well how to use their own smartphone cameras, which is a plus point, that we just have to assist them to get good get good anterior segment imaging. As a result, he was able to send us serial images every 2 days. We could gauge the need of TABCL on thinning, and we could also see that the ulcer was responding to medications, and we could decrease the follow-ups for the patients just based on these images. Some of the high-risk patients, like mentally retarded children, can also be monitored in the clinic when they are not that cooperative. You can hand it over to their parents, and they are very comfortable to image and find out what the problem was, as in this case was with hydrops in a Down syndrome child. The training process is very simple. You can actually train your own staff and they can hand it over to the patients. It's very intuitive for patients to learn and send the images to the doctor, and you would notice that the quality of their imaging goes on improving as they keep sending you images every week. So you need not spend too much time with the patient to train this. Your staff can do it for you. Once integrated with the EMR, this will add a huge value to teleconsultations, and this will also open the doors for us for standardized anterior segment imaging on teleconsultations. It helps us to apply newer AI algorithms to diagnose various diseases like infections or any other corneal degenerations or scars, and this is possible now once this platform is standardized. Trying to incorporate this into our existing Connect Care platform, and we are in the process of validation of this for the use of teleconsultation, and we'll be out with the results very soon. So this was the story of Grabby, the smartphone imaging adapter, which is primarily used to save the visit of the patient. This is the team that has worked behind for the last 1.5 years to develop this. And I would like to thank AIOS for giving us this opportunity to present this on this forum. Thank you very much.
Thank you, Vineet. I think that was a very nice presentation. Dr. Rohit, would you want to give some comments?
I think he did mention a couple of things about, I mean, I was looking at what is the way forward, and he mentioned that he's looking at AI and other platforms to do it. But did you compare your work with different pixel cameras, or you feel that all or any cameras would do work the same way? Because one of the issues with any Google-based AI is that the cameras needs to be of very good qualities.
Yes, sir. So for this, we primarily tested it on 5 different companies' phones, which was Redmi, Oppo, which were more commonly available with the Indian population. And as you correctly mentioned, for AI, it's like Gigo, it's like garbage in, garbage out. You have to have a good quality image to first get this analysis. So I think that will come a bit way ahead, not initially to go with. To begin with, we were planning to set the platform where at least the image of cornea is coming in clear. Once that comes into place, we have a team in place which can boost up the images to bring you to a certain quality level. And once that is through, there are algorithms already being developed in place which then can be applied for the same.
Yeah, absolutely. I think that part was very well clear, very well covered. Thank you, Vinit, and all the best.
Thank you. Thank you, Dr. Rohit.
I think
we move on to the next one.
Yes, we move to the next one.
Dr. Parthasarathi is here.
Dr. Parthasarathi. I think his presentation is already there with us, and he was there with us. Is he there? He is very much there.
Yes, ma'am.
Yes.
I am here. Can you hear me?
Yes, sir. Yes, sir.
Share screen.
Yes, sir. On slide presentation. On the yes, sir. Perfect. We can see.
Good evening, everybody. I am now presenting my invention. A squinted person has a stable personality. I have no financial interest to disclose. This is the published article on this subject. Von Muden exemplified how 2 siblings, a 8-year-old girl and her 6-year-old brother, both having same magnitude of hypermetropia, reacted differently when confronted with excessive accommodative effort to see clear. Due to difference in their personality trait, the girl exerted excessive accommodation and saw clear but squinted, and the boy instinctively relaxed accommodation to remain orthophonic but saw blurred. Von Muden further stressed importance of personality by commenting whether the visual system reacts with isotropia and clear vision versus orthophoria and blurred vision depends less on the degree of hypermetropia than on a child's personality. He also noted mutually opposite personality traits between these two groups of children as represented by the girl fastidious and exacting nature and boy easygoing and relaxed nature. However, he felt that their observational impression needs to be substantiated by an appropriate study. But Dr. Nuden's contention remained unanswered for more than 3 decades until a study on this subject for the first time in the world was taken up by the present presenter, who published an article in 2017. Jones defined neuroticism as vulnerability to neurosis, which implies low tolerance for stress, whether it be physical, as in painful situation, or psychological, as in conflict or frustration situation. Therefore, as per Jones' definition, the boy and the girl in von Muten's example had a painful and frustration situation of asthenopia and diplopia, and confronted a psychological conflict situation whether to relax accommodation and severe or exert accommodation and severe. Hence, according to my hypothesis, the boy in the example had low tolerance for stress and thus had neurotic type of personality, and the girl had tolerance for stress and therefore had a stable personality trait. Therefore, the bottom line of development of concomitant squint is to choose a conflict situation between phoria and tropia, clear vision versus orthoporia and blurred vision. Hence, it is evident that the development of squint is a function of child's personality trait. There are ample evidence also that a child's personality trait is carried forward to his adult life. Therefore, the presence or absence of phoria or tropia in an adult may be indicative of his personality pattern. A myopic student population was selected as sample for the study. It can be safely presumed that these students in their childhood faced the psychological conflict situation as described above and ended up with either exophoria or nophoria according to their personality trait. In this study, personality was considered as a cause of phoria and not an effect of it. 58 myopic students were included in the study. The personality of the students were determined on 2 dimensions, neuroticism and extraversion, by Maudsley personality inventory for 48 questionnaires. And at the end of answering, each student was examined for presence of horizontal phoria at distance and near by means of prism bar cover test. Now the result, the Fisher exact test comparing 2 groups, phoria and no phoria, and 2 outcomes, n value less than 24 and n value more than 24, shows highly statistically significant p-value. However, the same test with E-scale shows no statistically significant p-value. From statistical analysis of the results obtained in the study, it is seen that 81.08% of those with phoria will have a chance of having stable personality pattern compared to 33.33 of orthoporic, which have such chance. This difference is highly statistically significant. Therefore, phorics will have a high tendency to have a stable personality and low tendency for neurotic personality. This was evolved by the study. Thank you.
Thank you so much, sir. I think that was a very useful observation to make. And anybody has any questions? Because with the statistical analysis also, and that too in myopes who were students and who were who knew about possibly the pathology also, this was evaluated. Thank you so much, sir. I think we will move on to the next presentation by Dr. Amar Pujari, Think the Unthinkable, and I will refrain from marking this presentation because he's from my institution.
Thank you, ma'am. Are my slides visible, ma'am?
Yes.
Yeah. Thank you, ma'am, and thank you everyone for giving me this opportunity. So I hope everyone is going to learn these things through AIOS platform. I will be able to reach so many people. So during pandemic, as we know, theoretical things went on, but the practical training or the surgical training affected very genuinely. So for that one, so many people went to wet lab and they saw what are the techniques available. So when we see into the literature, only the cataract or the basic training on wet lab is available. So no advanced techniques or no other regularly done surgeries are not simulated in wet lab. So work exists, but that is very limited, and that too on common surgery. So I have discussed some of the work previously, where like I have told how to do the corneal suturing, extraocular muscle surgery like recession, resection, and even buckling. But these were not enough. We wanted to do more because all the subspecialty senior and junior residents were suffering. So we wanted more. So what are the deficient areas? The deficient areas were mainly strabismus surgery, complex strabismus surgeries, glaucoma surgeries, IOL surgeries, and ocular surface surgeries, and iris repair surgeries, oculoplastic and refractive. So I tried to find a solution for all these things, measure this thing. So these are the complex strabismus surgeries, as you can see on the left side in oblique. So these are completely goat side, not human eyes. So we can identify the muscles and we can arrange in a infractus, lateral rectus, all the recti and oblique patterns. So we can simulate and can do all the surgery. So this is useful for anatomical teaching to the junior residents and for practice to the senior residents. So you can see on the left side, all kind of parts, sphinx, modified end, and total anterior positioning, all the infraoblique muscles surgeries have been simulated. In the middle row, you can see that the Farden surgery, nap surgery, augmented naps, and even Y splitting, all these surgeries have been simulated. On the right side, you can see the superrectus and supraoblique has been simulated. Here, Harada Ito, posterior tenet of the supraoblique, and even tucking, all can be simulated. So total number of residents I have trained till now is 22, including senior and junior residents. So similarly in glaucoma, apart from trabeculectomy, which is commonly done, so wall implantation surgery and practice on how releasable sutures are put. So this is for junior resident, how to tell them how exactly this functions, and for SRs to practice. And this is the third thing where like complex IOL surgeries are being simulated. So I told my resident how to put IOL in the sulcus by inducing rent voluntarily, and how to put the IOL in the antechamber. So different sort of IOLs we place in a wet lab so that they can put in any place whatever they want. On the left side, you can see to simulate SFL, which is commonly done by cornea and refractive senior residents. So we took two multiphase IOLs, we joined them together, and we are able to simulate a SFL scenario. So similarly, iris repair surgeries like pupilloplasty and iridolysis, these are very interesting surgeries for senior residents, which they do often, so they were lacking. So using Prolian sutures, we were able to simulate in goat side, and we were able to replicate in more than 6 residents. So similarly for refractive, so of course we are not able to take the laser machine to the wet lab, but of course we are able to take some kind of square edge IOL so that we can simulate, or we can just ask them to do a phakic implantation by injecting the IOL. So similarly for residents who are going to retrieve the eyes, corneal eye bank, so how to retrieve, how to cut the corneal buttons, that we practice them. And most importantly, everyone is going to get a Pterygium surgery. We simulated that also. So to conclude, in wet lab, a significant number of routine ocular surgeries can be simulated to improve resident surgical skills. So these are some of the publications related to wet lab training, which covers all specialty, including retina, cornea, cataract, extraocular muscles, plasty, and all this. Thank you.
Thank you, Amar, for that presentation. Any questions from anybody?
No, very impressive.
Thank you.
Very nice, Dr. Amar. I think it's your life's mission to get on to hands-on training. I've seen you present so many times, and I'm really wondering how many goat eyes have you harvested so far? On a lighter note. I think never have goat eyes been used so much into training. And by now, goat eyes will be costing more than goat meat. But excellent work, excellent work. I really admire your passion to teach. And really, I think all through our residency, we knew only goat eyes being used for suturing, and maximum was IOL placement. But right now, I think you've taken it to the limits, and and now actually you'll have to have experts go and enucleate the goat eyes, so you have the muscles and the optic nerve part intact, so you can use all of it.
Yes, sir.
The harvesting is going to become another training.
Yes.
Thank you very much.
Wonderful job. I also have a passion for why surgical training was lacking in this COVID era.
Yes, sir.
And that was the reason we started the SSTC labs and all these things.
Yes,
the only thing in your pie diagram was missing was vitreous surgery. Anything?
So anything you are doing for vitreoretinal surgery, Amar?
Yeah.
Sir is not asking. That is the only thing.
I know you are an TS segment guy, but vitreoretinal surgery.
That's the next project.
Yes, sir. I have described buckling surgery, sir.
Yeah, I heard that. Buckling is basically suturing only.
Yes, sir. And we are doing is via surgery, sir. We are setting a setup. So in future, in another 6 months, I will be presenting that one, sir.
Well, all the best. All the best, Amar.
Only a comment, Amar. Have you noticed that the goat's eye iris is actually a lot more thicker than the human iris?
Exactly, sir.
So that's a little catch over there.
Yes, sir. Yes.
So
Thank you.
Thank you, Amar, for a very nice presentation. And now I'm going to invite Dr. Megha Nair, who's going to be talking about iOverter.
Good evening, ma'am. Good evening, everybody. Thank you for this great opportunity. Am I audible?
Yeah, Megha, but we can't see your presentation. We can see it.
Okay,
Yeah,
one.
you have to click it.
Okay. Is it visible now?
No.
No, Megha. I think you'll have to open it on your laptop.
You just stop screen share and again go to and open the thing and then start screen share.
Okay.
I think going from what Amar was showing, this is something which we had also planned, and Dr. Nayak sir is, I think, here, which was this wet lab was planned a couple of years ago at the headquarter, AIOS headquarter, and we are going to take it forward under his leadership and leadership of Dr. Lalit Verma as well. And this is something that has been there, and in the COVID times, no better times to see that we do require this. And sir, Dr. Nayak sir, would you want to say something?
Right, because the moment I heard this presentation, because I am also quite a big fan of practicing on the goat's eye and in the wet lab, because I myself did a lot of surgeries in the wet lab on the goat's eye. So, and the dog's eye, where I was trained in the dog's eye. So the moment I heard this lecture, immediately I thought of that in our center we should have this facility when we come up. I mean, shortly we will be planning that training center, in that this will be one of the major attraction, I suppose.
So Megha, can we have your presentation, please?
Ma'am, is it visible now?
Yes, perfect.
I'll be starting my video now.
No, Megha, the audio is not there. Audio is not there. Audio is not there.
One second now.
Yeah. You'll have to again optimize the...
Dr. Megha, you'll have to stop sharing, and when you start sharing, there is a checkbox, optimize for sound and optimize for video clip. Share sound, computer sound. It will be there on the sharing screen. Just click on share screen. Select your presentation. Don't click share, and on the bottom left you will see there are small checkboxes. Can you see that?
Yes, sir.
Click those. What is written on those checkboxes? Share.
After checking share screen, yes, sir. Optimize sound. Yes, share sound.
And there is another one also, optimize video wala. There are two checkboxes.
Yes, sir. Yes, sir.
Okay, now I think it will work. Now try.
Okay.
Okay.
So is it visible now?
Yes.
And
Perfect now. Perfect.
Okay, thank you.
iOverter. Eversion of eyelids has been a skill-based technique performed by ophthalmologists using their hands. Often it has been proven to be a challenge in situations such as patients with no eyelashes or mudrosis, those with deep sockets, in uncooperative patients, especially children, and in infective conditions with copious amount of discharge. But the risk of spread of infections through contact during COVID-19 pandemic raised this challenge to a higher level. It was time to come up with a better idea to evert the eyelids without touching. Eversion of eyelids using fingers occurs by combination of two forces, a pulling force by fingers on the eyelashes and a pushing force by the fingers on the upper tarsus. So we thought of recreating these forces without using fingers. Many models were tried. Finally, they were narrowed down to a very simple instrument made of only two materials. One, a double-sided tape, and second, an ice cream stick. The ice cream stick was cut at one end to a length of 3.5 cm and a breadth of 6 mm so that it fit just below the upper border of the upper tarsal plate. To the cut end, a double-sided tape of length 3.5 cm and breadth 5 mm were stuck to. The following video demonstrates the use of eye water. The eye water can be used in routine OPD examination. It has a universal usage in all patients including adults, older and pediatric age groups. It can be manipulated to see the area of interest. Also, double eversion can be tried using this instrument. A similar model was created using 3D printer using polylactic acid. The eye water can be reused by sticking another double tape over it after sterilizing it. Its uses include to examine the upper tarsal conjunctiva and superior fornix, to remove the foreign body in the upper tarsal conjunctiva, saline wash in chemical injuries, to examine swellings of eyelid like internal hordeolum and chalazion, to examine lid pathologies. Helps avoid transmission of infections between doctors and patients, easily sterilized, very cost effective and economical.
Very simple and nice, Chitra.
Chitra, yes.
Oh, much fun.
Would like to comment, Chitra?
Yeah, I said it's very simple, nice and so useful.
So thank you, Megha. That was the simplest way of, averting the eyes. And again, very innovative, something that is doable by everybody. So with this, we move to the next presentation by Dr. Dipankar Das. What's new of Fluorescein stain in ophthalmic pathology?
Is my slide visible? Hello?
Yes, you just started your screen sharing, but we can't see the slides. Yes, now it is. Yes, perfect.
Respected chairpersons, experts, good evening. I'm presenting my innovation of fluorescein stain in ophthalmic pathology. Financial disclosure nil. Move my slides.
From the bottom arrow on the left side, on the left corner, there would be an arrow which would be pointing towards the right.
Okay. Yeah. So this clinical situation 1, where we can see a corneal ulcer.
No, Dr. Dipankar, yes, perfectly all right now. Yes. Okay.
Clinical situation where corneal ulcer and the infiltrate was seen, and this patient's scraping was done, and it showed a drug deposits and careful fluorescein stain done on the scraping showed a fungal element, and it was confirmed by 10% KOH stain. Second situation is a eviscerated specimen with uveal tissue vitreous and post-PK corneal case with IOL, and the intraocular lens and the vitreous showed fungal element. And after 3 days of permanent section, we have seen fungus in GMS stain. In situation 3, we see a optic nerve tumor in an enucleated specimen, and just putting a fluorescein drop in the specimen over the optic nerve
you can see the calcified seminoma bodies, which after 3 days, when HND stain was done, you can appreciate the same seminoma bodies in that area. Now, in this situation where a cyst-like structure was given by surgeon from OT, from orbit, the fluorescein stain was done in this, and it shows a protoscolex with various calcified bodies. And you can well appreciate in fluorescein stain the different structure of Echinococcus species, and it is better than even HND stain slide, which was done after 4 days of permanent section. So eye pathology is very unique, as transparent structure are present in different parts of the eye. And the aim of the study is to see the sodium fluorescein dye usefulness for staining raw specimen in ophthalmic pathology. This was a laboratory-based observational study. Now, this fluorescein stain was taken from FFA angiographic room and in a 3 ml available vial, and the pH was maintained between 8.2 to 9.6. Now, this drop of fluorescein was put on the slide, which was uncoated, and then the contact times were just for 30 to 45 seconds, and it was photographed, different pathologies were photographed under objective of microscope. Now, you see the sebaceous gland, for example, in frozen section were studied, the enucleated eyeball, particularly for retinoblastoma seeds, choroidal melanoma seeds, and other cells. The RP cells in different pathologies were studied. Now, RB seeds were compared with the drusense. RB seeds had typically honeycomb-like appearance, unlike the drusense. The transparent retina with the blood vessel and retinal pigment cell, etc., were seen for different pathologies. Fat cells and IOL haptics and optics, for particularly for biofilm and pigmented and fungus, were analyzed. Now, this is a in forthcoming IGO article. There's a comparison between RBC by fluorescein and HND stain was made. You can see out of 35 retinoblastoma cases where seeding is being seen, all 35 cases fluorescein picked up the seeding, whereas around 50% cases HND stain picked up the seeding. Just to say, when you process the sample, some of the seedings are being, because they are very fragile, and some of the seeding are eliminated. Now, you see, there are in fluorescein microscopy and confocal microscopy, which are very, very expensive, costing crores of rupees. But our study can be done in cost-effective in a simple light or compound microscopy. In future, this stain can be used in vivo in various surgeries, such as brain surgery, to demarcate the tumor, for various endoscopy in the viscera and other parts, as well as dermoscopy can be done to locate the fungus in the skin, etc., directly.
So
now, septic fungus, parasites, thank you. Parasite, viral inclusion bodies, various infectious pathology were documented effectively by this staining. Pigmented cells, fungus in IOL surfaces, RBC compared with drusen that I've already told you, parasitic identification, and retinal pigment epithelium for various pathologies has been documented. This study highlighted a novel method of rapid staining of cross-ophthalmic pathology specimen. So far, we have taken more than 5,500 photographs of different pathologies pertaining to eye and other areas. Now, we know the theory of everything, as Professor Einstein and Stephen Hawking, where a particular stain can be used in so many cases. So the innovation right from the anatomy, the tumor, that is pathology, infection, that is microbiology, in a rapid, easy, and a most cost-effective way. And these are some of the publications that we have made, and some are coming in the forthcoming peer-reviewed journal. And just to quote, in observable science, there's always something in everything. And these are my acknowledgement, our patient, clinician, pathology lab. And thank you very much for patient hearing. I'm happy to take any questions. Thank you very much.
Thank you, Dr. Dipankar. That was a spectacular, beautiful presentation, full of colors. And sometimes we really wonder why we didn't think of these simple things before, and In fact, all the presentations today were like that. They were so lucidly, clearly done. And you wonder why you never ever thought about it before. But wonderful correlation, and like I said, even the microbiologists and pathologists have to learn from ophthalmologists now on, how to do things in a more easy manner.
Thank
Dr.
you.
Partha, anybody else would want to say, Partha?
Excellent, excellent way of demonstrating these, images. One thing again, Dipankar, with your scientific mind, I'm sure you have the whole set and the whole series, which possible because of the time frame, you were not able to demonstrate. But what is the approximate numbers about of the 5,500 photographs that you have taken, and correlation with the other staining procedures, other imaging procedures?
All these cases are seen in fresh specimen. Means after fixation in the formalin, next day when they are after crossing, I put the fluorescein drop and seeing what is there. So immediate diagnosis. All these cases has been subjected for a HND stain. So, and other special stain, for example, GMS for fungus, PS for basement membrane, then Elsian wood for mucin, and other special stain. For example, it's a amyloid Congo red. But thing is that this stain, is most important thing is that of this stain is that in vivo diagnosis. For example, I have shown a echinococcus which can be picked so nicely. Suppose there is a echinococcus in the liver and the open biopsy has been made. Just putting a drop of fluorescein, which is not toxic to the tissue, can demonstrate the organism itself over the liver directly. If you have a microscope, as Dr. Showed by modification of a what you call smartphone, okay, and you can document those things. Suppose the endoscopy you are doing and you are seeing that there is a possibility of either a stricture because of in the esophagus, because of fungus, or by cancer. Dysplasia can be picked up in this case and fungus can be picked up. So by putting an endoscopy, and even in the brain surgery, what is important is that suppose one very important difference between a meningioma and a glioma. There is something called arachnoid gliomatosis. What happened? The glioma, in spite of spreading to the pyometer, they comes down and into the subarachnoid space, and here they confuse the glioma with meningioma. In superficial biopsy, in this superficial biopsy, if you put a drop of fluorescein in OT with a high power handle microscope or a objective microscope, you can pick up those things directly by the surgeons. So this innovation can lead to the certain things of the rapid diagnosis and differentiating between a tumor, organisms, and other pathologies.
Thank you, Dr. Dipankar. And now we come to the last presentation by Dr. Hirika Gusalia on ASPI, anterior segment photography with intraocular lens.
Good evening, ma'am. Thank you for the opportunity, ma'am. Can you see my screen?
Yeah.
Yes, ma'am. I'm going to play the video. Hello, fellow residents. So today I'll be talking about my journey in the first year of residency. It was a year or more ago I entered my dream hospital as a first year resident after passing through all those hurdles of entrance exams and counseling. First week into the residency, I was clueless, so many new things. How do I use the slit lamp? What do I have to see? What findings are my seniors talking about? Being a curious child, I kept irritating my mentor and he tried the level best to teach me. Few months went by. I started using the slit lamp. But every time I saw an interesting finding in the patient, I had to rush him to the slit lamp photography room, which was on another floor of the hospital. It was inconvenient for the patient and time-consuming as well. I then started using the smartphone adapter, which could be attached to the slit lamp. It was a good tool but needed a lot of adjustments, and it was tiring to keep removing it and putting it again and again. then CAMS, Vision Center, peripheral posting started, where all I had was a dot sometimes. I wasn't sure of my findings a lot of times. Also, emergency nights would be frustrating. All I could do was explain my seniors about my findings on call so that they could help me with the further management of the patient. We used ASPE, anterior segment photography, with intraocular lens as an innovative learning and teaching tool for all residents, irrespective of the availability of expensive slit lamp machines. So let me tell you how I made my ASPE. First, take a chart paper and a scale and a pen to draw a rectangle measuring 10 cm 1.5 cm. You cut it out with a scalpel and then take a scalpel to just mark the center part of the rectangle and fold it across. Then, after folding the chart paper, you use a double-sided tape, stick it on one side of the chart paper, you stick it properly, and then we take a puncher to punch a hole in between the rectangle. To make a small opening where we can attach the intraocular lens. You then remove the other side of the double-sided tape. You take the 15 diopters intraocular lens and attach it on the circular opening. And then you stick the other side of the chart paper and sandwich the intraocular lens on both the sides. I then take my smartphone and attach the ASPE onto the smartphone camera with a micro feed. And it's ready. There you go. Switch on the flash for better pictures. Oh, that's me taking ASPE picture on a patient in an outreach camp. So now I would like to share you my ASPE picture collection. I hope you don't get jealous. These are few of the lid pathologies. Conjunctival findings. Cornea-related pathologies. Iris-related and pupillary-related problems. Uvea-based pathologies. These are few of my cataract-related findings. These are intraocular-related findings and complications. Many of my batchmates started using them after my great experience, and we now have a WhatsApp group called ASPE Club, wherein we discuss and share interesting critical findings of pictures on the group. I would suggest ASPE for every resident. It's a simple, low-cost, innovative tool which can be useful for every resident from first to final year, and it requires no specialized training. It can be used for case discussions, treatment, publications, photo documentation in a rural or emergency setup devoid of city labs. Thank you.
So thank you, Harika. You were the youngest, I think, and the simplest of the presentations. Thank you so much.
Yes,
In your residency, you have keen observation power. Now I would request all the judges to please forward their marks to Mr. Kripal Rana, who will be compiling these, and very soon we'll come out with the result. And meanwhile, we would request all the esteemed expert panelists as well as judges to give their feedback. I would request first Suven, you're there, and then
Yeah, I'm there.
yes, Suven. So what do you make out of it, in the sense that we talk about patents? So what do you think? What sort of a issue should go in forward? Like you very rightly said, that patent itself costs so much. Do you think that we need to convert our patents into commercial product ourselves, like you've done so very well? Or whatever you have done, do you think we should approach the companies? Because I know that it is very difficult to get your things, patented through the companies, because then that thing is a,
Yeah.
different ball game. But having said that, you cannot sell your own product. So you do need a company in between to, sell these products for you.
Yeah. So thank you, Namrata, for the opportunity. See, the thing is basically we need to first identify whether ours is an invention which is patentable. So for that, it has to have novelty and it has to qualify certain criteria, because once you start investing time and money into it, it will be difficult to back off, and each inventor is very convinced that he's got the greatest invention on earth. That's for all of us. So we need to bounce our ideas. Now, before we bounce our ideas, we need to protect our interests. So whenever you talk to anybody, whenever you discuss with anybody, we need to sign what is called a non-disclosure agreement. So even if it's with a company, it is not very expensive to file a patent in India. So the initial cost of filing, you can file a provisional patent, it costs only 1,800 rupees. So it's not such a big deal. But that is not going to be a complete filing. You could carry on that and file that. So but then the legal fees is what costs a lot. So if you think that a person has got a patentable invention which can be commercialized, and the cost and effort spent in patenting is going to get returned, then it's definitely worth going. So that judgment has to be very critical. And before you share your ideas with the company, you have to protect your interests by signing a non-disclosure agreement. And then as things go by and as the development phase, because you have a lot of time when you're filing patent, you have a lot of time. So you can improvise, have your prototypes, and then see whether it practically works, have peer reviews, and then you see how you want to commercialize, whether you want to keep it within the country or go overseas and things like that. So if it's a good thing, there'll be a lot of takers. If it isn't great, well, you'll have your feedback. But then sometimes it's your conviction which takes you forward.
Sir, Dr. Lalit Verma, sir, what would you say about the quality of?
I would say don't lose an opportunity. You see, if 21 thinking brains could impress, 4 or 5 of us, so they should not lose an opportunity. Get in touch with experienced people like Suven and take all the help whenever possible. Take his advice, because he learned from the mentors. So these are the people who will take you forward, because I saw a lot of very young people who may not know the tips and tricks of the trade. Like Suven said, therefore I've said don't lose an opportunity. Talk to him and he will guide. But I would say, Namrata, AIOS has taken a leap forward by taking this session in such a great way. And I would, although I had told you that I may not be available, I could not move an inch. And 2.5 or 3 hours, I would say, well spent, great learning by all the innovators. And maybe some gray hairs of mine will get stimulated.
So, Kripal, have you got everybody's?
We send it to the same email ID, Namrata, your official email ID, that is?
No, you will. Kripal,
Kripal send it from your ID. Kripal send it from your ID.
Secretary.org.
Okay.
I have WhatsApp to him actually.
Yes, that's fine, sir. He will.
I can do that also.
Yeah, I had his numbers.
I must compliment AIOS on this. Starting from Lalit sir, I think he took it on himself and started this innovator sessions. And from then on, I have been getting a lot of calls, and it's very interesting to get involved with these youngsters and guide them. So often I have 1 hour long calls with some of them. And then I think Namrata, Maipal sir, all of you have taken it forward so well. And now these opportunity for them to present and get viewership. And that kind of, is a lot of encouragement for them. And trust me, I had a tough time marking these. They're just within 1 mark of each other.
I know.
How do I mark them? It's really unfair. It's a test for the judges.
Maybe I can suggest to Barun Naik sir to जितने भी 21 sir presentation यहाँ हुए, maybe we can institute an award, maybe a travel fellowship or something to present abroad so as to showcase talent. Maybe Chairman Scientific Committee can think about it, or Barun Naik sir can take it forward. But some stimulus to make them present in, say, bigger meetings. people who have won an award, say 1, 2, 3 here, they should,
think
should
it's a
take
very,
them.
it's a
Yes, sir.
brilliant
Surely
idea.
we will have sponsors to do that. Dr. Nayak, sir, would you want to comment on that? Or on the entire session, sir?
Yeah, and I will agree that, and by now she has realized that, just like as Lalit said, that he he said earlier he will not come, but ultimately he stayed for the entire. And same, I think Namrata will appreciate that usually I don't attend
Yes.
webinars.
Yes, sir.
But if I attend and if it is interesting, first of all, if it is a topic is interesting, something useful, then definitely I do attend. And but in this one, I also didn't move out at all. And in my house, I was told that ye kaam karo, wo karo, but still I said, no, let me finish this, then
Thank
we
you, sir.
listen each and every one in entirety. And one point I want to highlight, and because you see, as Partha had earlier started that thing under the apple tree, so everyone saw it, apple falling, but no one thought why it is that. Similarly, a lot of things which was discussed here, a lot of people observe, they see, they do, but otherwise they don't think that, oh, I am thinking something different or something which is, it should be propagated or it can be taken advantage of, which I saw. It's really, I was impressed with everything. And one point probably I just want a clarification, because I have no experience in that in patenting, which Suben can tell me, that in India I have been told that it is the process which is patent, process also is patented. So if someone is coming at the same end, but process is different, then probably that patency will not be holding true. Am I right, or
Sir, in India, processes are not patentable. In India, in the US, you can patent a process, let's say surgical process or a process to a thing is patentable in the US. In India, processes are not patentable. Designs and this thing are patentable. So we have more of a design patents, or what we call utility patents. That is what is available in India. We cannot process patent processes. No, we can't in India. Like a surgical procedure in US, you can patent even a surgical procedure, a surgical technique.
No, not only that, I was not meaning that surgical procedure, means attaining the same end object. If your process of attaining that is different, then probably it doesn't come under the, means it doesn't protect you from the patency right.
So if you're talking of computer programming, that's an entirely different thing. But processes as such are not patentable in India.
Okay, so
processes are generally not, and I mean that again will be how the lawyer, the patent attorney phrases it, and they are the experts to decide. But to the best of my knowledge, processes are not patentable. It's mostly the utility patent, which is mostly about design as something new, de novo, which you have created, or a modification of an older product is also there when there is a significant inventive step.
Okay, so that yeah. So that everyone should take advantage of this information is all this about. And if someone has any query, they want to proceed further, move forward, then definitely Suban is the right person.
Always available, sir.
And he happily said that he doesn't mind even 1 hour means on spending 1 hour on phone, because it is well spent on phone.
Always.
And same way, means whatever means I have passion for. If someone calls me and asks even for 1 hour, I also don't mind, but I should have passion for that. So I am really thankful, Suben, and we will think what future can be done. But one idea simply I got, that in our wet lab at the training center in AIMS, in RPC, sorry, AIOS headquarters, we will definitely have that wet lab of those surgical practices, because for that you are because in practicing on wet lab is entirely different ball game. Because one part which is always missing in that, when you are doing actual on the patients, because mentally you are not worried that I am going to harm the patient, but in the wet lab you are always assured that whatever it comes, but at least I am not going to harm anyone. So that basically itself makes you more perfect, because this I have noticed when I started doing my deep sclerectomy, non-penetrating anti-glaucoma surgery. Then that time, means practicing on human eye, it was really very fearful that I have to go so deep that I can straight away go on dissecting and hit the Schlem's canal. But when I started doing it on human's eye, which was not fit for corneal transplant, then in that means in the first time I could straight away go deep, dissect properly, and hit the Schlem's canal. So that gives you more confidence. So that practice, and as I said earlier, because right now every next door you have some trainer for any kind of surgery in your city. But when we were doing surgery and started doing implant or extracapsular, because in the beginning extracapsular also was a great thing, I spent a lot of time in wet lab on dog side, and having all those different kind of movement, even suturing also, which looks very simple when the experts are doing it. But when if someone you might have watched 100 times, but once you do it yourself, even on the in the wet lab, then you realize the difficulty that, oh, how easily it was done by the expert, and now I am finding it so difficult. And because one example always I cite my students that in the beginning we always used to, with the von Graffis knife, when we used to give incision, then we had to hold the lower limbus with the fixation forceps with the multiple teeth. That was so difficult to hold that, because I can't tell you, it looks very simple if the experts were doing it. But now, and I am sure now probably no one has even, the youngsters might not have even seen that step, because that is not in vogue, that surgery. So it's on the whole, all in all, it was a great session, and I loved it, I enjoyed it, and I'm so happy that so many people have come forward in presenting their innovations.
So I think now we do have the results with us, and we will start from the back. So we have 5 appreciation certificates. So I would request our chairperson, ARC, Dr. Chitra Ramamurthy. Dr. Chitra, have you received positions 5 and positions 4 on your WhatsApp?
I'm sending, ma'am. Sending.
Okay, so I would request her to announce position 5 and position 4 for appreciation certificate. Meanwhile, any participant would like to say something or would like to give some comments, or all the participants are here?
A quick comment.
Can we have all the participants' videos, please?
Yeah, before Partho speaks, I must say that under the apple tree also has been a great opportunity for innovators, and it was Partho's brainchild, and then now Dr. Chitra has taken it forward. So it's wonderful. Lots of opportunities for innovators nowadays.
Yeah, I think a big word should go to the mentors of our innovators.
Exactly. I just thought, Partho, this idea came to me just now, that next time we will have mentor-mentee kind of a session where we will invite the mentor and the mentee both with the innovation.
Hello, ma'am. Hello, ma'am. I am Dr. Partho.
Yes, sir. Yes, sir.
I want to make a comment, ma'am. I have been seeing even in the Think Under the Apple Tree and throughout this session, that there has been a trend to push the science back and taking technology in front. All the presentations are dependent upon the technology. There are practically no presentation that is based on science.
Okay, sir. I think
we have been trained in anatomy, physiology, biochemistry, and all the medical subjects.
Yes.
Where are those subjects gone?
Okay, sir. We will keep in mind.
So you take the initiative to encourage scientific innovation, not only technological innovation.
Surely, sir. I
It
think
is
that's
your
a very-
job, madam. It is
It's
your
a, it's
job.
a, it's a very good suggestion, sir. A very valid suggestion. I think we will keep that in mind also for future.
Unless being in the apex body, you do not set the trend, then what direction
Surely,
our
sir. Surely,
innovation
sir.
will go?
Surely, sir. The point is really very well taken. Dr. Chitra, have you got the... Chitra, you are muted. You cannot be muted at this, moment when everybody is waiting you to...
Ma'am, एक मिनट मैम एक मिनट.
Just one comment I want to make on Parsarthi's remark, that when we evaluate these, it's not that we are just seeing the glory or but definitely the eye basically see what is the utility, whether it is mass applicable, and whether it is simple or very complex, or whether it has involved a lot of experts involvement, and someone who is very simple and did it themselves. So definitely I give more weightage so far as this session is concerned. And so it's not that everything is being considered, Parsarthi. It's everything is being considered when we evaluate. Thank you.
So Dr. Namrata, should I announce?
Yeah. Yes, please, Chitra. Appreciation award.
मैम एक मिनट मैम डॉक्टर चित्रा मैम एक और भेज रहा हूँ मैं आपको मैम.
Actually, there is a joint this thing. So it's a shared thing. So you will probably need to announce 3 names.
Okay.
At position 5 and at position 4.
Actually, it was very close. So it's very difficult to mark. So there are going to be many people holding the same position.
Yeah.
So I think we will have another one next year.
Suspense बढ़ता जा रहा है. Suspense बढ़ता जा रहा है.
We will have another one next year at the same time, like we had first time. Yes, Chitra.
First and foremost, congratulations. I had told Namrata I might be able to stay only for a few minutes, but it was like a magnet and it attracted me to watch all of you, and terrific performance by you. Such a out of the box thinking. You all should really keep on doing it because it's a rare talent. And I'll start announcing the results. The 5th appreciation certificate is shared by 2. One is Dr. Hirika Gosalia and the other is Dr. Megha Nair. Both of you get the fifth position, and congratulations. Fantastic.
Congratulations to both of you. Both of you are residents, and it's a tremendous,
Thank you so much, ma'am.
tremendous this thing for you.
Very special talent you all have.
So thank you so much, Dr. Chitra. Thank you.
4th appreciation certificate goes to Dr. Dayakar Yadala. Congratulations to you.
Congratulations, Dayakar. Congratulations. Yeah. Thank you so much, Dr. Chitra. Now I would request Dr. Partha to announce certificate appreciation position 3, 2, and 1.
Thank you. And in that same order, Namrata, I'm going to announce the winner of the 3rd appreciation certificate. This is something that we always would understand, and no other than Dr. Amar Pujari. A big applause to Amar. Fantastic. And Amar, you've already gone into the headquarters now with Dr. Varun appreciation for you. The 2nd appreciation certificate is for Dr. Vineet Pramod Joshi. Congratulations, Vineet. Really great, wonderful work.
Thank you, sir.
And the 1st appreciation certificate to Dr. Alay Banker. Alay, congratulations.
Thank you, Dr. Partha. Thank you for doing the honors. Now I would announce the 3rd prize winner of the Innovators Forum, and that is the most spectacular presentation that we had, which is by Dr. Dipankar Das. So many congratulations, Dr. Dipankar. Keep doing the good work.
Thank you, everyone. Thank you.
Well done, Dipankar.
Really nice.
Thank you, sir.
I would now request our President-elect, Dr. Lalit Verma, to announce the second prize.
Let me hear. The second prize, any guesses? Because a lot of prizes have already been announced. Goes to none else than Nilesh Kumar. Congratulations, Nilesh.
Thank you, sir.
Congratulations.
Thank you
Wonderful.
so much, sir.
Where are you? Where are you?
Sir, here, sir.
Yeah.
Thank you, sir.
Like anything.
You'll see 4 images of the Nilesh.
Thank you, sir.
And now I would request sir, you would like to say something before we ask Dr. Naik sir to announce the first prize winner of the Innovators Forum.
Open the suspense very fast.
Okay. Dr. Naik sir. Dr. Barun Naik sir.
Wait, can we
Paul,
check it?
are you there? I think, yes, sir.
Yeah, sir.
So I would request, sir, Dr. Barun Naik sir, President of All India Ophthalmological Society, to announce the winner of the second Innovators Forum 2021.
And now it's already the other awards have been announced. So the suspense I am going to break. But before that, I want to be doubly sure. So again, I am going to check with Kripal whatever I heard is correct or it's not.
I think, sir, the winner will, would want to check whether he has heard or she has heard everything correctly or not.
The stakes are getting higher.
Yeah, I know.
Suven, no suspense.
That has already said he or she, yeah?
I said he or she, so I...
Gender neutral.
Gender neutral, yes.
Hello.
Kirpal.
All in the hands of Kirpal.
Third time confirmation. I think
तो सारे मार्क्स उन्हें नायक सर को भेजने चाहिए थे.
So I think the innovators should continue to innovate, and we are going to be having these kind of programs, which we are having very frequently. We started with the COVID innovation because when the COVID actually came, we didn't know how to go about it, and then there were a lot of our AIOS members who helped during that time with innovations, how to go about it. So, sir, is the result? Are you going to announce the result?
Baby is going to be out, and the winner is Dr. Prithvi Chandrakant.
Many congratulations, Prithvi.
Very good.
Prithvi, where are you? Prithvi, kahan pe ho?
I was so sure about
Can
that.
we have spotlight on
Prithvi? Where is Prithvi? I can't see him.
Yeah.
Congratulations.
Many congratulations.
Thank you. Keep doing more and more work. Don't stop at all.
Yes.
So many congratulations to everyone, and of course, each one who participated here is a winner, and we are going to be sending the certificates to each one of you very soon. And we are going to put all these videos also on the website, which are going to be indexed and catalogued for everybody to see. So thank you very much, everyone, all the participants, and all the judges and the panelists who actually sat through the whole thing, despite saying otherwise. And thank you very much, everybody.
The only request is, Namrata, please carry this forward and please communicate with all members that you are going to, have more such sessions which will promote more innovations. No, Suvin?
Yes, sir. Yes, absolutely.
Okay, great job done.
Thank you, sir and madams, everybody. Thank you so
Well, and
much.
all participants.
Thank
Great
you.
job.
Thank you, sir. Thank you so much. Thank you, ma'am.
Thank you, and we would like to thank our audiovisual team at the back, Dr. Anand Sethi, Sharik, and everybody, and Mr. Kripal, most importantly, for putting everything in order. Yeah, he was everything. He was the one who aggregated all the videos, then put up all the scores together. So thank you, Kripal and the back office team in the AIOS headquarters. This today has generated so many ideas, which Dr. Barun Naik sir said that we are going to have a wet lab, and so many ideas came out from so many presentations. I'm sure all of them can be taken forward.
Okay, bye-bye.
Bye-bye.
Thank you. Thank you.
Good night, sir. Good night.